Good morning, everybody. Can everybody hear me? Awesome. I am the Community Advisory Board member for the Queen's Hospital Center, and I'm also the President and CEO of the Sickle Cell Awareness Foundation Corp International. And it gives me great pleasure to be here this morning so I can thank Mr. Moore, Mr. Edwards, and the team from this hospital that we work with cohesively for giving us the opportunity to host this symposium here today. Thank you so very much for allowing us to be here. Most of you are aware how serious sickle cell is. And we have worked tirelessly in our community, not only to bring awareness, but to let people understand the importance of when someone has sickle cell and they go to a hospital, the care that is needed for our patients. So I am not going to dwell on explaining sickle cell because we have our beautiful doctors on standby to discuss every detail on sickle cell. So without further ado, I would bring up Mr. Trevor Wilkins, our MC for today, for him to get started. Thank you so kindly for your time. Have a blessed day, everybody.
Thank you very much. Thank you, Marlene. Thank you. Thank you for coming out tonight. Thank you for supporting Sickle Cell. Good morning. Good morning to everybody. Sorry. Good morning. Hope you guys are well. Thank you so much for coming. My name is Trevor Wilkins, and I have a radio show on 91.5 FM. It is the greatest calypso show in the world, and it airs every Saturday on 91.5 FM. And it's been around for over 25 years. And what we do every Saturday night is basically discuss and play calypso music, the classics from the 1940s, the 50s, the 60s, and really educate our community on our music and our health. And how music actually is good for your health. You know, music really, stimulate your brain and exercise your mind. And, so music is good for your health. So if you get some time on Saturday, please listen to my radio show on 91.5 FM. And plus, I'm streaming live around the world as well, simultaneously on trevorwilkinsshow.com. Today is really a good day for me to come out and talk about sickle cell and to be here among the doctors and to learn and to really get an idea of what's going on with sickle cell. It is quite interesting, and it is very important to me that I learn as much as I can about this, because my darling sweet neighbor who lives across the hall from me died from sickle cell. And, I got to tell you, she looked normal all the time. She looks great. And one day she went to the hospital and never came back. And, she always told me she had sickle cell, but I never really knew what. I thought it was just something normal. It's not a big deal. But apparently it is. It is quite pernicious, and we need to be very careful. So if we can get the word out to the community and reach out to our friends and family and get them to understand that there are places they can get information on this and we can help each other, it'll be great. So thank you all for coming out. Thank you for coming here and learning more about the advances. I think we have the top doctors here that will explain it. So I don't want to take up too much of the doctor's time, because, once you're on radio, you tend to talk a lot, I'm always, always talking, the music, the calypsonians, the singers. So I'll leave the talking to the doctors. So we got some fantastic doctors with great information, really information to help you not just stimulate your brain, but to give you an understanding of the disease. And I think you'll be really, when you leave here today, you really should be able to take some information with you home to your community and your friends and family. So my friends, I hope we get a nice little warm welcome here. No further ado, I want to welcome Dr. Abena Appiah-Kubi, and she is really special. She's been around a long time. And I just want to give you a brief background on this doctor who is very special to the community. And I'm sorry. Oh, excuse me. Okay, apparently the doctor is coming on after. Let me just welcome remarks here from Mr. Moore, Mr. Neil Moore, to come and say a couple of words, and thank him for coming today, and thank you all as well. Sorry.
Good morning. Good morning. This is another great day at Queens Hospital Center. My name is Neil Moore. I'm the Chief Executive Officer here at Queens. And it's just nice to see some familiar faces around. I just ran into someone whom I've known for more than 20 years, maybe more like 25 years. I haven't seen her, and I was glad to see her this morning, Shirley Lindsay. Nice to see you. We worked together many years ago at Kings County Hospital. I am very grateful that we are hosting this symposium covering this important topic. We have here at Queens Hospital some wonderful employees. I refer to them as ordinary people doing extraordinary work here at the hospital. And I'm proud to be the CEO here for a hospital that responds to the needs of the community. I'd like to thank today all participants in this important program, as well as those that will be joining us later. I know that we have some elected officials who are expected to be here as well. And even in their absence, if they're not here as yet, I'd like to thank them, because it's our collaboration that makes us stronger and better in doing what we do in providing healthcare services. Here at Queens Hospital, our awareness that sickle cell disease is prevalent in the Southeast Queens community, our team has been hard at work in making advancement to address this disease. Our doctors, our nurses, our allied health professionals, and many others do a really phenomenal job here at the hospital. The fact that no other disease better exemplifies the effect of racism in healthcare than sickle cell disease. We all have an intuitive understanding of what that means, but the actual data is very heartbreaking. While the mortality rate for children, I'm told, is decreasing, the overall mortality rate for sickle cell disease is increasing, with young adults having the highest rate. And the doctors will tell you more, either corroborate or to give you much better information, since they're firsthand here to talk with you today. These healthcare inequities are simply unjust and reflect the low priority given to sickle cell disease as we compare to other chronic diseases because of whom it affects. The Sickle Cell Awareness Foundation, one of the premier sickle cell organizations in New York City, is engaged in an ongoing partnership with Queens Hospital to tackle these inequities. For its part, Queens Hospital has a comprehensive sickle cell program that provides the best of care for individuals and their families affected by sickle cell disease across the lifespan. Working together, we are dedicated to eliminating disparities in care for this debilitating illness. Queens Hospital offers individuals with sickle cell the opportunity to participate in clinical research. As the hospital is part of the American Society of Hematology Sickle Cell Clinical Trial Network. This is an exciting program, and it is designed to increase the number of drugs available to improve the lives of people living with sickle cell. In addition, Queens Hospital is working with both the American Society of Hematology Sickle Cell Disease Learning Collaborative and the Federal Health Resources and Service Administration Sickle Cell Treatment Demonstration Program and Quality Improvement Initiative. This is all part of our overall objective to eliminate the disparities of care and decrease the stigma individuals with sickle cell disease face when presenting to our and many other emergency departments in pain. Today's experts will be sharing much more in the way of advancements, as I stated earlier, in understanding and confronting this disease. I'm sure you will be inspired and leave here very much more informed than you are coming in. Unfortunately, I had a conflict this morning, and but I had to be here. I had to be here to welcome you and to be here to engage Mr. Teo, whom we've worked collaboratively on the Community Advisory Board. And I want to comment and say the Community Advisory Board at Queens Hospital works very, very closely with the overall hospital as well as our auxiliary. And we do the work that we do here at Queens Hospital because of that collaboration, because of the collaboration with our community. And so in closing, once again, I would like to say thanks to all of you for being here at this symposium, and I'm certain that you will be much more informed today than you were coming into the meeting with the wonderful panel of physicians that we have. Thank you very much.
Thank you very much, Mr. Moore. I just want to welcome on stage and get some greetings from Mr. Stephen Monroe, if he's here with us, to share with us greetings and, of course, talk to us about sickle cell as well. Thank you. Sir.
Good morning. My name is Stephen Monroe. I am the staff representative at Queens Hospital Center, the labor chair and co-chair of our joint labor committee. I represent the ordinary people at Queens that do extraordinary work in this neck of the wood. And I wanted to take this opportunity to welcome you all in the best community-based hospital in this neck of the wood. And I extend that to the state of New York, soon to be the best community-based hospital in the country. We at Queens, we take our job very seriously. As Mr. Moore alluded to, ordinary staff doing extraordinary work. And you know what? We leave no patient behind. Our patient is important to us, and our patient comes first. And today's symposium is a very important symposium on the topic of sickle cell. As a young man, I've seen some of my friends who didn't make it and is not here with me today. They passed early because of this disease. I think that sickle cell disease is a disease that needs to be, the highlight should be given more. I think more funds should be plugged into this area, because it's a disease that is not dealt with in an equitable manner among African American and Black population. And so it is my aim for this symposium today to expose, to bring the much attention to this deadly disease. I've seen working in our own emergency department, I've seen patients coming in and they're being misunderstood with pain. And I could say that I have a brother who have the trait, but I have friends who are full-blown sickle cell patient. And I get an understanding what the pain is like just by being close to them. but most of the time, sometimes the pain is being misunderstood. And so it is very fitting for this symposium to be held here today. And so it is my intention that this symposium will bring a lot of relief at the end of the day. I know that our elected officials are not here with us. I hope that they will come by the end of the day, but I bring greetings to them. And so I wanted to thank you all for coming out here this morning. And I would have liked to see more men in this auditorium, because sickle cell also affect men. And somehow it's hard sometimes to get our men folks just to go and get us the screening. So as we sit and we listen to our experts at the table, if you know a friend who might be suffering, encourage them to go and get the regular checkup and get the regular screening. And so that is my welcoming to you all. And I hope that you have a wonderful time being here at Queen's Hospital Center. Thank you.
Good morning, everyone. My name is Molino Sotillo. I'm the Vice President of the Sickle Cell Awareness Foundation. And is glad to have you guys here this morning that to show some sort of support for our event today. You will be here to know a little bit more about sickle cell, and I'm sure that's when most of you or all of you leave here this morning. We have some wonderful speakers that you all would be able, that what you didn't know before, you would have the opportunity to ask questions and maybe get some of the best answers at this point in time. We are happy to introduce our next speaker, who represents District 28 Office of the Council Member and Speaker of New York House, Senator Council Member Adrian Adams. This young man here is a delightful young man. His name is Tyrell Hankerson, and he will give us some remarks this morning and blessings of what the council member have bestowed upon this organization and to every one of you here this morning. So please welcome Mr. Ty Hankerson.
Good morning, everyone. It's always good to be called delightful. So, my name is Ty Hankerson, and I serve as the District Chief of Staff for New York City Council Speaker Adrian Adams. And today, just wanted to bring a few opening remarks or brief remarks on behalf of the speaker who couldn't make it today. So, as we are all aware, sickle cell disease disproportionately affects Black and Brown Americans. In fact, about 1 in 13 African American babies are born with the sickle cell trait. And the disease is found in about 1 out of every 365 Black births, according to the CDC. It is also common among our Hispanic communities. Overall, sickle cell disease impacts nearly 100,000 Americans, with roughly 10% of them living here in our state of New York. Yet not enough people know what it is or the pain that it actually causes. It is imperative that we increase public education about sickle cell disease. It's imperative that we eradicate the stigma around it and support our fellow New Yorkers who are afflicted by it. I'm sure everyone in this room knows someone who suffers from sickle cell anemia. The New York City Council will continue to champion and support efforts to provide additional resources toward that goal. We have funded community-based organizations like this one to raise awareness and empower families suffering from the sickle cell disease, including the Sickle Cell Awareness Foundation Corporation, which is actually located in our district, District 28. Thank you to Merlene and Molino for your leadership and your continued passion. The council will continue to facilitate the expansion of the New York Blood Center, which provides blood, cell therapy, and research programs to help treat the complications of this disease as well. The New York Blood Center collects blood throughout New York City and the tri-state area and has the largest inventory of rare blood types in the world. While we have so much to do, the council, and of course, my leader, Speaker Adams, will continue to be partners with all of you in this work. So thank you for bringing awareness, and thank you for sharing with your friends and family and your neighbors and letting them know about this important and vital topic. This is how we spread the awareness, and this is also how we make folks destroy that stigma that oftentimes surround diseases like this one. So thank you all.
Thank you so much. I hope that you guys relax and enjoy what you're hearing so far. We're going to get some really good information about sickle cell, complications about sickle cell, which I am dying to hear, because I think it's going to help me really understand this disease and what we're dealing with, sickle cell. You know, you hear about it, but you never really quite know what it really is. And you read about it, and, you know, you have to be a doctor to try and figure out what's really going on. So anyway, we're going to bring on one of the famous doctors who's in our area, in our community, in the battle, in the trenches, fighting for sickle cell every day, seeing patients, know exactly what it is, going to explain to us the complications of this, and really bring it home to us and enlighten us here. So this is where we really try to see if we can get a real understanding of this disease. So my friends, you know, and I told her to already forgive me in her name, but her name is Dr. Appiah-Kubi, and she's got a wonderful background in sickle cell and what she has done as a doctor in our community. I mean, Dr. Kubi is an attending physician at Cohen Children's Medical Center, an associate professor of pediatrics at Zucker School of Medicine and Hofstra Northwell. A part of the sickle cell program, she helps care for over 500 children and young adults living with sickle cell disease. Her goal is to prevent the best, to provide the best clinical care to her patients by access to current disease-modifying therapies, enrollment on research studies, and education in increasing awareness about SCD, sickle cell disease. So she is no stranger to sickle cell disease, and this is where we get an understanding of the complication of this pernicious disease. Would you please put your hands together and welcome Dr. Kubi? Thank you, Doctor.
Good morning, everyone, and thank you for joining us on this Friday morning. Let us see here. No, you're actually not. Yeah, no, you guys are not blocking at all. I was just trying to say enable content, but I can't figure out how to. It's not on my screen, it's only on that screen. Let's say enter. And hopefully you guys will be able to see all the slides. And if you can't, we'll figure it out. Okay. All right. Well, thank you for that kind introduction. So we'll just get right into it. I just feel like at every sickle cell event, it's just important to highlight why we do what we do and why we care so much about taking care of individuals living with sickle cell disease. So before, I think, the title of today's theme is talking about treatment and things like that, but without knowing what the disease is causing, it probably won't understand why we have the treatments that we're offering. So in the few slides that I'll share with you today, I'll just give you a brief introduction about sickle cell disease. We'll focus on some complications. There are quite a few, so we won't be able to do all of them. And if there are little tidbits here and there that I can mention about how you may be able to prevent them, I will share that with you then. I would say we will have the panel discussion later, so maybe jot your questions, comments, concerns in your phone or something, since most people don't use pen and paper anymore. And just so that we can make sure to address it when we're having that discussion then. So sickle cell disease is a genetic disorder of the red blood cell. You end up with this abnormally shaped red cell, which is not nice and round and can easily flow through the blood vessel. But in its sickle shape, it gets stuck, it breaks apart, and it leads to all the complications that we have. So again, this slide just shows you normal red blood cell, nicely flowing through the vessel, and then the sickled ones, not so great. Since it's a genetic disorder, you do get it from your parents, which means you are born with it. And, if anybody ever asks that question, which gets me a little upset. But if your parents are carriers, that means they have sickle cell traits. Then with every pregnancy, there's a 25% chance they can end up with a baby with sickle cell disease. So that's every pregnancy. If you end up with one with the first pregnancy, unfortunately, still 25% with the next pregnancy. And so that is, again, with every pregnancy. Sickle cell disease, these are the main origins of it, but due to migration, it's really just about everywhere now. And I also like to just show you this, just to show why we have sickle cell disease in the first place. It's because individuals with sickle cell trait who live in areas that are endemic to malaria, they actually thrive better. And so the gene just gets passed on from generation to generation. Sickle cell disease can affect everyone, though the majority are Black and African American. I was actually joking with my Chinese colleague that he would never get a sickle cell patient. And the very next week, he actually ended up with a sickle cell patient who was visiting from Taiwan and then went back home. But yes, due to migration, it can affect anyone. So imagine this little boy here has sickle cell disease. He is subject to lots of complications. So we'll touch on some of these. Again, I don't think we have time to go through every single one of them. So anemia. If you hear sickle cell anemia, we're referring to the type of sickle cell that gives you anemia, which is usually the SS type or the S beta 0 type. The other types of sickle cell disease don't usually cause a daily anemia. You can have anemia in certain settings, like if you're sick, but sickle cell SS and S beta 0 thalassemia, they cause anemia on a daily basis. So the red blood cell doesn't live as long. Normal red cells are supposed to live about 3 months, and sickled red cells live about half of that time. And again, when the initial image where I showed you that abnormal shape, it causes the red cell to break apart. And when it breaks apart, it releases bilirubin, which can cause the jaundice that you can see in people's eyes. And it can also lead to gallstones. And so children with sickle cell disease can end up needing to have their gallbladders removed due to this complication. In regards to fevers and infection, every fever, and we tell our families, every single fever is a medical emergency. I don't want you to just treat it at home and say the fever went away, so okay, we're fine, we're just gonna chill at home and wait this one out. No, because I personally don't know which fever is caused by a bacteria and which fever is caused by a virus. So what can I do? I can actually kill bacteria if I can give you antibiotics, but I must do that in a timely fashion. And the only way I know to do that is if you come with the fever. So thankfully, yes, most of the infections are viral, and so most people survive it. But we don't want to take that chance with the one that's not a virus and it truly is bacterial, but we couldn't act in due time because you took Tylenol and Motrin and stayed at home. And when the fever came back, things were a lot worse. And so, again, I need to see you. You need to come. You need to get antibiotics. And you need to get a blood culture sent. And so, again, every fever. The main thing we're worried about is bacteremia. Like I said, I can't tell which one's going to be from a bacteria and which one's going to be from a virus. But since I can treat bacteria, I treat everyone as if it's a bacterial infection. And thankfully, hopefully it's not. The reason that we have the problem with increased risk of infections in sickle cell individuals is because their spleens don't function as well. The spleens helps us fighting infections, and it also filters our blood. In this first image here, you do see the arrow. I can't see it, but you can. But this is the spleen. That's the liver. But over time, due to what we call infarctions, areas of the spleen die off. And over time, when we look at the same thing again, the spleen is no longer there. And so the spleen function, even if it hasn't been surgically removed, it's not adequate. And so for that reason, every individual living with sickle cell disease is at increased risk of infections. To prevent that, we put babies on penicillin prophylaxis, and we also recommend immunizations. So in order to figure out that children with sickle cell disease needed penicillin prophylaxis, there actually was a study. They didn't just wake up one day and say, everyone must get penicillin. No, they actually studied it. And in this slide here, I show you the children who did not receive penicillin in the top bar, climbing, almost like climbing up the stairs, these guys. This is their chances of having an infection much higher, significantly higher than the children who are receiving penicillin. So they actually stopped the study and said every child needs to be put on penicillin. And that's why we would like to see a child with sickle cell disease by 2 months of age so we can start them on the penicillin. So they remain on it until 5 years of age. We change the dose as they're growing. And stopping it at 5 isn't an automatic on your 5th birthday, you stop. We also have to make sure you're fully immunized. And so we give you immunizations towards a bacteria called strep pneumo, and it can lead to serious infections and even death. All children, even without sickle cell disease, receive a vaccine called PCV13, and they receive that routinely at the pediatrician's office. However, individuals living with sickle cell disease also receive one called PCV23, which has additional strains of this bacteria for additional protection. So before we start the penicillin, we'd like to make sure you've received at least 2 doses of that PCV23. Meningococcal vaccinations are also important, and so usually the pediatrician would take care of that part and make sure that they're fully vaccinated. If your spleen is surgically removed, we recommend that you remain on penicillin indefinitely. So even though the spleen, doesn't work so great, and you're at risk of infections, unfortunately, you're also at risk of a very bad complication due to the spleen called splenic sequestration. That's when all your blood cells can get trapped within the spleen, and the spleen can become severely enlarged. It can cause a rapid drop in your hemoglobin, and it can lead to death if it's not identified and treated early. So at that very first visit, we teach every family how to palpate for the spleen. And if there are other family members that are taking care of the baby, we tell the parents you have to teach them too, because it's the individual who's with the baby who's going to see that the spleen is enlarged and then bring it to our attention. We're not there to figure that part out. And we just advise them, as you're changing the baby's diaper, just check it. It'll become almost routine so that you'll just know to check it every single day. And then we do tell them that, okay, if you feel it, that's a medical emergency. You call us immediately and bring the baby in. And so we can intervene and make sure that the baby remains okay. If it happens once, unfortunately, that means it can happen again. There's actually a 50% chance that it'll happen again. And eventually, if it keeps happening, we get a little concerned because we don't know which one of those events are going to be very significant and cause something very bad. And so we might, at that time, recommend that you surgically have the spleen removed, which, remember, after that happens, you must remain on penicillin. Sometimes we try to see if we can avoid that by doing transfusions every month. Sometimes it's successful, sometimes it still happens, and we end up having to remove the spleen. Another complication that can happen is pain. And that is, the hallmark of the disease. And pain is just, it's horrible. But it can start from very, very young ages. And in the picture, you see a young child with swelling of the hands or the feet, and that's called dactylitis. When they're older, they'll be able to tell you when they have pain. It usually affects the long bones. And what's happening is that area of the bone is not getting enough blood flow. And that's what's causing what we call an infarction, and is also leading to the pain that that the individual is feeling. It can happen, really quickly. And since there's no, in the baby, in this picture that I'm showing you, you can see the swelling of the hands and feet. So it's very evident, but you don't always have that swelling. And sometimes there's nothing there you can physically look at to say, oh, okay, this pain is there. And that's part of why some people have a hard time believing when someone's reporting their pain, because they're like, oh, well, you look completely fine. Sure. But the pain is still there and it's still happening, and it must be addressed. We try to equip you with things you can do at home to try to prevent you from coming into the hospital for a painful episode. However, sometimes, you still have to come in, but we do not want you to use ice ever. Ice causes more sickling. And that's why even like in cold weather, we want you to rest warmly, because once you're exposed to the cold, sickled cells just sickle more, and then that'll just lead to more complications. But you may use heat packs, that's totally fine. At our institution, we like to recommend ibuprofen, and we make sure every family is equipped with that. Just remember, you need to take it with food. We don't want you to get an ulcer on account of that. We also recommend oxycodone if the pain is severe. So if the pain is really severe, then just go straight for both. But if it's not so bad, you can start with one and then add the other if things aren't getting better. Oxycodone causes constipation, so you have to be mindful of that and make sure you address that. I mentioned you can use the two together already. And then if what you're doing at home isn't really helping you, then don't delay. Just get in sooner. The sooner you get in, the sooner we can get rid of it, and the sooner you can get out of the hospital. If you get there too late, then sometimes it takes us a little while longer to get things better. And there are other non-pharmacologic stuff you can do at home: warm baths, music. As you grow, people realize what works for them as far as taking care of their pain. Somebody mentioned magnesium baths to me the other day. I don't know much about that at all, I'll be honest. But yeah, so whatever works for you, you figure it out over time, and you can try those methods as well. So can you prevent a pain crisis? I already mentioned to you the thing with the cold. So sometimes you can. You have to stay well hydrated. Let's say it's the summertime, you want to go into the pool, hot sun, cold pool, rapid temperature change, not so great. Summertime again, steaming hot outside. You walk into the grocery store, the refrigerator section, freezing cold, rapid temperature change, again, not so great. And so just try to figure out what your triggers are, and then try to avoid those triggers. And that's one way you can help. For some females, it's that monthly menses brings it on. If that's the case with you, maybe see with a GYN, see if there are things you can put in place to try to regulate that. But did I mention no ice? Okay. Another complication is acute chest syndrome. The definition is fever, respiratory symptoms, and a pulmonary infiltrate. But I have to be honest, I am very loose with that definition. Why? Because the outcome can be very bad, including death. And so if I think it, you're getting treated for it. There's no back and forth, waiting for the chest X-ray to change. No, none of that. You come in, you have fever, you have respiratory symptoms, you do anything else differently, you're being treated for acute chest syndrome, because it can honestly just rapidly become this, which if your chest X-ray looks like that, chances are you're in the ICU, intubated, and that's what we're trying to prevent. So we act early, and yeah. In different age groups, it can show up differently. So actually, true story, just last week Friday, I had a parent refusing a chest X-ray And the kid came in with a fever, and they're like, well, he's breathing totally fine. How could he have acute chest syndrome? I said, well, that's actually the problem. He's too young for me to tell if he has acute chest syndrome. I actually need the chest x-ray in this case. I think it was a 1-year-old or something. And sure enough, that child had acute chest syndrome and received the appropriate treatment and is now out of the hospital. But had we delayed getting that chest x-ray because the parent felt it wasn't necessary because the child wasn't coughing, sneezing, or anything, then that would have been a problem as well. So sometimes we recommend things, you may not understand the reasons why. It's important that you ask so that we can explain it to you and make sure that we do what is right for the child in a timely fashion. In older individuals, it's evident, you can see they're able to tell you if their chest hurts or anything like that. We don't really know what causes acute chest syndrome. It can be infection. It can be what we call infarction. That's when the area doesn't get good blood supply. And sometimes when you have pain in your legs, there are these, it's called fat emboli. So basically wherever the pain is, let's say it's in your thighs, and your thigh bones don't, get good blood supply, they can shoot off these fat emboli, which then goes into your lungs and then causes the acute chest. So sometimes you come in and you have acute chest, but sometimes you come in for pain and then develop the acute chest. And that actually happens very frequently. So when you come in for pain, we're always thinking acute chest and trying to make sure your pain doesn't then become acute chest. But we always worry about infections. So we treat you for that. And if you're older, we also don't want you to have a blood clot, so we'll address that as well. But a lot of times we don't necessarily know 100% what caused it. Either way, we'll treat you for it. Make sure you're well hydrated, don't get dehydrated, give you broad spectrum antibiotics to treat potential bacterial causes. If you need respiratory support, that's a bad sign, and we would automatically at that time recommend a blood transfusion. You might know this thing that's called an incentive spirometer. It's a little thing with the ball in it, and you have to take a deep breath. And that is to keep your lungs open to prevent you from getting acute chest syndrome if you come in for one thing or another. But also, if you have acute chest syndrome, we strongly recommend that you use that as well. So I mentioned this earlier, but we transfuse early. We don't wait. It's not worth the wait. If you're worried about it, take care of it and take care of it early. And if your hemoglobin is low enough, we can just go ahead and transfuse you. Sometimes that's not the case and your hemoglobin isn't so low, but you're really, really sick, and we end up having to do a bigger transfusion, a more in-depth procedure. It's called an exchange transfusion. And I won't go through the details of it, but you get a lot more blood. You need a bigger IV. It's a lot more involved, but sometimes that is what's necessary. So we do everything we can to prevent you from getting intubated. That is what we're trying to prevent. So let's say you come in for pain. It's our goal to make sure your pain is well controlled, so you can take nice deep breaths, use your incentive spirometer, so we can prevent the acute chest from happening. And we also want you to walk around and things like that, keep your lungs as open as they can be. We're moving on to the central nervous system now, and our biggest complication there is a stroke. It can be overt stroke where you have, complications, you can't walk, you can't talk, things like that. Or you could have what's called a silent stroke, where when we image your brain, we see that there's a stroke there, but you actually show no signs or symptoms of the stroke. Maybe as a child, maybe they're just having like difficulty in school or anything like that, but they could have still had a stroke. Sorry, I just mentioned this already about having difficulty in school. So we do recommend neuropsychiatric testing if we can get it done. Hopefully the family agrees so that we can support the child appropriately as they're trying to make it through school. But since we know stroke can happen, we know to also screen for stroke, and it's called a transcranial Doppler. And some people are arguing that we should not call it that. We should call it a stroke screen. Because if we call it a stroke screen, then maybe parents will take it more seriously and actually get it done when we recommend that they should get it done. Because despite the fact that it's there, and despite the fact that it's easily done, it's a non-invasive procedure. It's literally an ultrasound. The child lays down, as you see in the picture. They put the probe on the side of the head, and they measure the blood flow and the blood vessels in the brain. And if there's a high velocity, we worry that that vessel is closing up. I always use this water hose analogy, where when you squeeze the water hose, you notice that the water flows through faster. Similar concept. But if it's not done, you'll never know. And then something might happen that you could have prevented. So we recommend this starting from age 2. And we only stop at age 16 because the skull bone is a little too thick at that time to get an accurate reading. And it should be done yearly unless if it's concerning, and then it's done a little bit more frequently. When we receive our result, it looks like this, and it just has the numbers on the left and right for the different blood vessels of the brain. Again, a study, and this is how they realized that transfusions are beneficial for preventing stroke. The red arrow shows you the individuals that were receiving blood transfusions, and the line below are the individuals who are not receiving transfusions. And this is just showing you the probability of remaining stroke-free. And so clearly transfusions was better than standard of care. And so for that reason, if your transcranial Doppler is what we call abnormal, then we would want to put you on blood transfusions to prevent you from getting a stroke. Now, let's say you already had a stroke, unfortunately. At that time, we would still recommend blood transfusions to prevent a second stroke, because again, this was also a study where after the child had a stroke, they randomized them. Some had transfusions and some didn't. And the group that didn't receive transfusions, they had more second strokes. And so we decided if you've had a stroke, remain on transfusions to prevent you from getting a second stroke. So other than transfusions, our other possible option is hydroxyurea, which we'll get into when our other presenter talks about treatments for sickle cell disease. But in this article, for which our other speaker, Dr. Aygun, is actually a co-author, they did find that for individuals who have an abnormal transcranial Doppler, that means you did not have a stroke yet. Your transcranial Doppler is just abnormal. After a year of transfusions, we can safely switch you over to hydroxyurea as long as your brain imaging is fine, and we can still prevent you from getting a stroke. And so we have several children who have benefited from this, but you do have to take the hydroxyurea for it to work. It was already mentioned, the life expectancy in individuals living with sickle cell disease. It has gotten better, especially for the pediatric population. But unfortunately, in the adult population, it's still not so great. So this is just showing you that there has been an increase in life expectancy. But I don't know if you can see the top of this. The top number is 50 years. So it's still, I mean, the general population is like, what, 80 or something? And so 50, still not so great. We do know that as you grow, you get more complications. And so we do our best to prevent most of them in your childhood. But the disease is a chronic disease. So despite our best efforts, there are some things that we are not necessarily able to get rid of. So our goal is to make sure you understand as you're growing what the complications are, so that when we recommend certain interventions and things like that, you understand why. But again, because it's a chronic disorder, the more you grow, the more problems you can have. So we'll talk about a few of those chronic problems. I'm not sure if you can see if there's anything wrong with this individual's eyes. They actually look quite pretty. I don't think there's anything wrong with them. And that's the whole problem. The eye complications of sickle cell disease is not something that I can just look at you, other than the jaundice, right? But that's not an eye complication. That's just a pigment issue. But the issues that are happening behind the eyes. So I need an actual specialist to take a look at that and inform me what's happening back there. Because if we don't do it, what happens over time, you have poor blood supply. You get new blood vessels that are forming, you can get hemorrhage, and then the retina detaches, and then you're blind. And this can happen quite early. You can have a 30-year-old who's blind because of sickle cell disease. But if we look early, then maybe we can do something to help. For example, there's laser surgery, that's an option. But again, if you don't know, you won't know that you need that. Unfortunately, this particular complication is more common in the SC type of sickle cell disease than the SS. It still happens in the SS as well, but it's more common in the SC. And so we do ask for you to see the eye specialist. And we used to wait till you were 10, but then unfortunately, a few younger individuals had it. And so we dropped the age back to 8. Chronic pain. We talked about, the acute pain when you come in acutely with pain. But this chronic pain it can just be there for forever. But because of that, it also needs to be treated differently. So your regular quick narcotic, morphine, Dilaudid, whatever, may not necessarily be what you need for this chronic pain. You definitely need something else because it's different and needs to be treated differently. And so we might recommend other things such as methadone, or we might recommend you see a pain specialist, or there are other things we'll recommend when it gets to this part. But then also, if we can treat the underlying cause of the chronic pain, for example, if it's an avascular necrosis of the hip and you could have surgery to potentially improve that, then maybe it's worth looking at that option to make sure that your chronic pain can be taken care of. It's not easy, and we don't expect you to do it on your own. Even as the provider, it's not easy for us. We never 100% know what to do. But I think if we work together, maybe we could come up with something that works for you. Every individual is different. So just because this combo works for this individual doesn't mean it's going to work for the next one. And so it's a team effort, basically. And so, like I said, it's a team effort. So psychiatry, psychology, social work, your provider, whoever your other supportive people are for your home, everybody will need to be on board to help you. And, just have a positive attitude and try to make sure you take good care of yourself. And then hopefully, we can get it fixed over time. Avascular necrosis is another complication. There are other names for it, but basically it's when the long bone or the joint doesn't get good blood supply. So one of the major areas that happens is in the hips. It can also happen in the shoulder. If it's really bad, you can see it on an x-ray, but we usually don't want to wait till it's that bad. So we always want to diagnose it when it's only visible on the MRI, because that means you caught it hopefully a little early and gives you the chance of intervening and hopefully getting the individual back to where they want to be, whether that's only physical therapy, whether it's just with intermittent pain medication. If you have chronic pain, like I mentioned, maybe you do need surgery, so you don't need pain medication all the time. Leg ulcers, they can happen as young as 10 years of age, but I'm not going to wait when I say this, but I'm very fortunate that in the pediatric side, we actually don't deal with it that frequently, but it can happen. Again, it's just not good blood supply, but there are some triggers such as trauma or infection. And so we would recommend that, for example, if it's due to anemia, that you would be on something to improve your anemia so that we can help your leg ulcer heal. We do need the help of other subspecialists, because as the hematologist, we definitely cannot heal this on our own. And then we have to make sure the infection, which is, superficial, doesn't end up going so deep that it gets into your bone, because then once that happens, that's a whole different issue. So you come up with a treatment plan with your provider and other subspecialists to try to get it under control. And then once you get it under control, then you're trying to keep it that way. Pulmonary hypertension. Thankfully, we don't also deal with this in the pediatric realm. It's one of those chronic disorders, so mainly in adults with sickle cell disease, you may see this. But because we are aware of this, we do ask that you see a cardiologist quite frequently to make sure your heart is okay. But it's basically high blood pressure of the pulmonary artery or vein. It's a special test. It's not as simple as putting a cuff and just getting it. It's an invasive test, but if they do it on the echocardiogram by the cardiologist, then that's a non-invasive way where they can get some measurements that would tell them that we're worried about this. And if needed, then they could go with something more invasive to verify. Again, you might have some symptoms, but you may not have anything. And so we just recommend that you routinely see the cardiologist to make sure your heart is okay. But if you happen to have symptoms, then for sure it is worth looking into to make sure you're okay. And some of the symptoms are listed there. And like I mentioned, we want you to see the cardiologist to make sure your heart remains okay. And we like to be a little bit ahead. So our main thing is always prevention, prevention, prevention. So if we see it early, maybe we can intervene instead of waiting till you already have it and then trying to figure things out then. Then we have renal complications. I don't know if you've realized, but almost every organ is getting dinged by sickle cell disease because blood flows from, all over. So any part, we've talked about the brain, the heart, the lungs, and here we are talking about the kidneys now. You can lose your ability to concentrate urine. So what that will lead to is frequent urination. So some teachers might give the children a hard time thinking they just want to go play and they just want the bathroom pass. So no, it's probably true. They probably do need to go use the bathroom a little bit more frequently than other children. And so in our 504 for our students, we actually put that in there that, let them go to the bathroom if they need to. We monitor their urine to make sure there's no protein in it. We usually do that annually. And we also want to make sure there's no blood in it. If we see any of these in the urine and we're concerned because it doesn't automatically clear up, then we will ask you to see the nephrologist to make sure that things are okay. And then for our men or boys living with sickle cell disease, they have a problem called priapism. And that is repeated or unwanted and painful erections. And so this needs to be addressed because if it occurs frequently, then it'll lead to your inability to have an erection at all. And we don't want that for our young men. So if we notice that you're having this frequently, then we might recommend a treatment plan to try to prevent it. So again, this is something we won't know unless if it's shared with us. And so you have to be comfortable enough with your provider to tell them that this is happening so they can help you. So those are a lot of complications that I just went through, maybe rather quickly actually. So hopefully if you have questions, we can talk about it later. But overall, just have a positive attitude, trying to live a healthy lifestyle, taking good care of yourself, knowing what your triggers are, listening to your body. Like we have some of our younger children who run track or play at a sport and maybe they have a little bit of pain, but they're like, no, I'm going to do this. And then by the end of the track meet or by the end of the game, they're in the hospital. But had they listened and just maybe sat out for that one game, maybe they could have avoided their pain getting so much worse. So just you listen to your body, try to figure out your triggers, try to be ahead of the game, and prevention is what we want to do instead of waiting till we have a problem already, and talk to your doctors and make sure that if your doctor is asking you to see somebody else, it's because whatever it is they're asking you to see them for, they can't do it on their own. And we really do need you to see that other provider, whether it's the cardiologist, the ophthalmologist, the pulmonologist, because you have asthma as well, anything like that, so that we can try to do the best to prevent some of these complications. However, there's also treatments, and we will hear about these treatments in another presentation, but we used to have like a couple of things on this list, and now it almost fills up the whole slide, and that's really exciting. And so thank you for your time, and I look forward to everything else we're going to hear about today. Thank you.
Thank you so much. Wow, that was some information, right? I mean, after hearing all that, I thought hypertension was tough, but hypertension is nothing to when you listen to this. This is real, and we worry about little things in life, but can you imagine you having this as a child and trying to subsist in the world, trying to exist? It's unreal. Anyway, we're going to continue. We have another doctor coming up to give us some great information on sickle cell. Again, welcome to everybody who showed up today for the symposium. Really happy to have you here today so we all could learn about sickle cell and take it back to our communities and our friends and our families, and actually really try to see if we could disseminate some of this information and give back a little bit to the community. So I want to welcome Dr. Banu Aygun to come on the stage and talk to us about basically some of the theories and the therapies that we have in sickle cell and what we can do. So please give her a warm welcome on the stage.
Good morning, everybody. First of all, I would like to thank Mr. and Mrs. Sutillo and the Sickle Cell Awareness Foundation, Queens Hospital Medical Center, and all of you for being here today. It's a pleasure for us. Today, I'm going to be talking to you about gene therapy. Let's see. Start my slides, and I'm going to put on glasses because I'm so young. Okay, all right. So, we'll talk just a little bit about the genetics of sickle cell disease, since the title is gene therapy, and how do genes come into play. We'll talk about stem cell transplantation. And I have to say, this is the same thing as bone marrow transplantation. It's just the new name for it. So when I say stem cell transplantation, I mean bone marrow. And then we'll talk about gene therapy and what it means and how it is done. So as Dr. Appiah-Kubi mentioned earlier, sickle cell disease is a single gene disorder. And it's actually the genes are coming from your parents. And the person who has sickle cell disease has 2 copies of the sickle cell gene. And this could be whether SS, SC, S beta 0, or S beta plus thalassemia. And these genes actually affect the red blood cells in the body. As you can see, this is the 2 globin chains. They are called 2 alpha and 2 beta globin chains. And when you have sickle cell disease, it affects the beta chain and it causes the sickle hemoglobin to occur. And again, this is the hemoglobin molecule showing you the 2 alpha and the 2 beta. Who feels like we are in biology 101, right? And who thought we would ever need it again, but we do every day. So again, it's a single gene difference, right? Instead of the A, we have the T. And because of that, we are actually making a different hemoglobin molecule called the sickle hemoglobin. And that's what's causing the red blood cells to sickle. So the normal red blood cells have this, discoid shape. I kind of say it's like the donuts. They're soft and they can squeeze through small blood vessels. But when you have sickle cell disease, especially under certain conditions, the red blood cells take this sickle shape. And actually for children, I say they're like bananas. But that's where the name of the disease comes from. When it was first described in 1910, they looked under the microscope and they said, oh, these red blood cells look like the sickle that's used in the fields. And that's how the name sickle cell disease came about in United States. But actually in Africa, there are very many different names to the disease. None of them mean sickle. They're actually all associated with pain. the names that are describing sickle cell disease. In any case, I sidetracked a little bit. But so when the red blood cells sickle, actually they can cause occlusion of the blood vessels, so blood cannot flow to that part of the body. And that's why we see all these complications that Dr. Appiah-Kubi has told us about. So stem cell transplantation or bone marrow transplantation, why do we even talk about it? How does bone marrow come into play? Bone marrow is actually where we make all the blood cells. So since sickle cell disease is a red blood cell disorder, these sickle cells, or the parent of those red blood cells, are also produced in the bone marrow. And the genes for sickle cell disease are there in the parent cells of these red blood cells. So that's where it comes from. And so when we do a bone marrow transplant, we actually, this is how it looks like, right? Your bone, and inside that bone, you have that red part. That's the marrow, and that's where all your blood cells are made, including your sickle cells if you have sickle cell disease. So if we actually remove all your parent cells from the bone marrow, and right now we are doing it with chemotherapy and sometimes radiation therapy, and then if we give you cells from somebody else who doesn't have sickle cell disease, now you don't have sickle cell anymore, right? So actually, this year is the 40th anniversary that a child with sickle cell disease was first transplanted. It happened in 1983. A child with sickle cell disease developed leukemia, acute myeloid leukemia. And in order to treat her leukemia, she underwent a bone marrow transplantation. And after the transplant, she was cured of both diseases, both her leukemia and sickle cell disease. And she's still living and well. That's how long transplant has been done for sickle cell disease. So then you might ask, why not transplant everybody then? Wow, it's been done for 40 years, right? So there are a few challenges. I would say one of the biggest challenges is finding a donor. Because in order for us to do a successful transplant, we have to find a donor whose white cell typing matches your white cell typing. It's different than blood group. It's called HLA typing. It's human leukocyte antigens. And here you can see this is how it's listed. So it's not like ARH positive, right? You see all these numbers. These are different antigens that we're looking at. And we want to find the person who matches you 100%. In general, so this is very much like sickle cell disease in a way. You get one copy of these antigens from your mom and one copy of these antigens from your dad. So there is 25% chance with each sibling that a sibling might match you if you have the same parents. So again, I don't want to just belabor this too much, but look at this patient. This part of the genes came from the father, and this part of the genes came from the mother. And looks like, this sibling 1 is a full match. But sibling 2 got the other half of the genes, so sibling 2 is not a match to the patient. Okay? So again, 1 has to be a full sibling having the same parents, but even with that, there's only 25% chance that a sibling will match you. If we do not find a sibling that matches you, then we look at unrelated donors. So these are volunteers all over the world who want to be a bone marrow donor, who want to save a life. And they have done a blood test or a buccal swab, and we have their HLA typing on the computer. So when we have a patient who needs a bone marrow transplant, we actually put our patients typing into the computer and see if there's a match all over the world, all right? And as you can see, unfortunately, as for if you're Latino, 55% chance that we may not be able to find a matching donor. If you're Asian American, 60% chance. If you're African American, 75% chance that we cannot find a matching donor for you, or if you're multiracial. So why is that? Part of it is, I think we have to encourage our communities to become a donor. So if you do not volunteer, and if you did not do that blood test or the buccal swab, your information is not there. I don't know your HLA typing. You might be matching my patient, but we have no idea. So this is in the United States, most of the time, this is done through the National Marrow Donor Program. That's how you become a donor. And they usually have desks at fairs and other events. And you can always, volunteer. The second problem we have with transplant is called graft versus host disease. So as I said, let's say we found a match and we gave the cells to the patient. Those donor cells may think of the patient's body as foreign and say, I'm gonna attack. This is not my body. These are immune cells. These cells know what's me and what's not me. And they're designed to attack what's not me, to protect the body. But now these are somebody else's cells in my body and thinking that my body is foreign. It is foreign, right? So we have to make sure that doesn't happen. So we actually treat the patients with medications that suppress the immune system so that these cells learn to live with the body, and also the body doesn't reject these cells. So they kind of learn to live harmoniously. So these are the two main reasons I would say, that sometimes prevents us from going to a bone marrow transplant. And this complication happens more frequently if we do not have a sibling match donor. And what are the results for transplantation for sickle cell disease? How many people have been transplanted so far? So this is actually a paper describing the European experience. France has a very active transplant program, and they have already transplanted. As you can see, the transplant started 1986, immediately after the 1983 patient. So they have transplanted 1,000 patients. They were all HLA matched sibling donors. Overall survival is 92%, and event-free survival is 91%. These are very, very high rates. And this is a combined experience. This was reported from US. In this paper, they have, again, almost 1,000 patients, but as you can see, the donors are different, right? Most of them are still HLA matched siblings, but there were what we call haploidentical. So these are parents who donated bone marrow, but they are only matching 50%. Okay, and the transplant is done a little bit different. Or they are unrelated but matched, and unrelated and mismatched. So the best survival was seen with the HLA matched sibling transplants. And also best results were seen in younger patients, younger than 12 years of age. And this is just showing the results using different type of donors. This is event-free survival, and this is overall survival. The blue line is an HLA matched sibling. You can see that the best outcomes are seen when you use an HLA matched sibling. The red line is the HLA match unrelated donor, and then these are haploidentical and mismatched donors. So this means, so over 80% are surviving, but then especially with unrelated donors and haploidentical donors, there are other problems that are happening to these patients. So this is from American Society of Hematology, and they recently actually published transplantation guidelines for sickle cell disease. And they're recommending that we do the transplants prior to 13 years of age to prevent complications. As Dr. Appiah-Kubi showed in other slides when she was talking about how complications increase with age in sickle cell disease, first of all, you would like to transplant a person before they had any of these complications, because if a complication happened, a chronic complication, most of them are not necessarily reversible. If a child had a stroke as a child, I would transplant them, but then their stroke still stays in them. It's not like I can regenerate the nerve cells and the child may start walking again. Kind of think of it that way. So we would like to transplant before those complications happen, but also as the children grow, they are exposed to, for example, more blood transfusions. That in itself can lead to problems after transplant. They may have iron overload. That can lead to problems. So that's why this is recommended. So overall, if you look at transplant, only less than 14% of the patients have an available matched sibling donor. And we actually actively send HLA typing on our patients in our clinic. And I know we have families who very much want to do a transplant, but the child does not have a donor. And then, as I said, there are also other problems such as graft versus host disease or graft rejection. So can we use gene therapy instead? So when we talk about gene therapy, we are talking about using the person as their own donor. So we don't need an outside donor. We're going to use the person living with sickle cell disease as their own donor. And there are important steps in this. One is we have to inform the person of everything that can happen during this treatment and afterwards. We have to get their stem cells. We have to do something to their genes so that we will change the course of their sickle cell disease. And then we have to give the bone marrow cells back to the person. So there are several strategies with today's technology that we can do that. One of them is correction of the S gene. It's a single gene. It sounds very easy, but it's been worked on for 40 years in very good labs, and it is very, very difficult to do. The other possibilities are inserting the normal adult hemoglobin gene and make the person sickle cell trait, basically. They start producing the normal adult hemoglobin, or increase fetal hemoglobin so that they're not taking a medication to increase fetal hemoglobin. Their fetal hemoglobin, baby hemoglobin that we are all born with, stays on throughout life. So I'll give you examples of the two of them. One of them is actually gene addition, inserting the normal hemoglobin A gene into the cells. So in order to insert, so we have to take the patient's stem cells, right? And in order to be able to insert a gene into that stem cell, we need what's called a vector. Vector is the Trojan horse, okay? So whatever gene we are interested in putting into the stem cell, we cannot just insert it into the cell just like by itself, put the gene there. So we have to cover it with something so the cell, it can go into the cell doesn't eat it up, and it can go into the nucleus and can go and attach itself to the right place. Very, very important steps. So in order to do that, currently, we are using lentiviral vectors, the HIV virus particle, so not the virus itself, but the particle to do this because this is a very smart virus. So I'm going to talk to you about one study that's doing this. It's called 8GB206. And these were the enrollment criteria to be on the study. The patients had to be between 12 and 50 years of age, had to have SS, S beta 0 or S beta plus thalassemia, have to have severe pain crisis that required admission to the hospital, at least 4 episodes within the past 2 years, and they had to have tried hydroxyurea, be on hydroxyurea, and still have severe disease. And the outcome of the study was they wanted to see more than 75% reduction in severe pain events in 24 months after the gene therapy. And they also want to see complete resolution of those events. They also want to see what the hemoglobin level is without transfusions. So this is how it works. The patient comes, and you can see my arrow or no, or you cannot see it. Abena, how did you make it show on this? No? It's okay. Okay. Okay, that's fine. So let's start from the upper corner. So we bring the patient in. We actually collect the patient's stem cells. And we do that. We give them a medication which tells the bone marrow, push all the stem cells out into the blood. And we actually collect them from the bloodstream. So we collect the cells, and then we send the cells to the lab. The lab inserts the gene, does lots of quality controls, make sure the gene inserts in the right place, make sure all the cells have the gene, they're all working. And then they freeze the cells and tell us, okay, the cells are ready. Then we bring the patient back. Now, if we just give the cells back to the patient, you know, those cells have no place to go and call home because the bone marrow is already full of cells. So we have to actually get rid of the cells that are already in the bone marrow, patient's own bone marrow cells. So we give chemotherapy to wipe out patient's own sickle cell bone marrow cells. And then we give the new modified cells back to the patient and wait for those cells to grow again, which takes about 3 to 4 weeks. So this is our patient who underwent this treatment. This is actually when we collected his stem cells. He's showing you the bag, just looks like blood, right? That's how bone marrow looks like. And then we sent it to the lab. And this is when he's getting the cells after chemotherapy. You see, this is just a tiny bit of the very tiny bag. It's white. It's all the stem cells. There is no red cells, nothing else in it. And he's getting it back. So there were, total of 50 patients in the United States who consented to be on this study. And about 40 of them actually got their cells back. So they were, remember the criteria were 12 to 50, so most of them are young adults. Median age is like 24. And there are very few pediatric patients, only 9 of them, roughly equal, female and male. And most of them had hemoglobin SS. And most of them had very severe pain episodes. Some of them had acute chest syndrome, Dr. Appiah-Kubi mentioned. Some of them had priapism, and 6 of them had a history of stroke. And so this is also telling us how many times did we have to collect stem cells from the patients to have enough cells to give back. And we had to, in most of the patients, they had to do it twice, but in some patients they did it once, some patients required 4 times. And this is telling us how many days did it take for the new cells to come up. So neutrophils, the white cells came out in about 20 days. The platelets, it took about 30 days. And they stayed in the hospital an average of a month, 35 days. And I feel like this is the most important slide. This is all these different patients, all the lines, and you can still not see my arrow, but each blue line is a different patient, and the red dots are the different pain episodes they had prior to gene therapy, and the yellow lines are after gene therapy, and there are no red dots. All right, so nobody had a severe painful episode requiring hospital admission. This is showing their hemoglobin levels. And remember, we are not actually taking out patients' hemoglobin S. So they still have it. So green is hemoglobin S, but red is hemoglobin A, the normal adult hemoglobin. So prior to transplant, they would have been just green, SS, right? They are not producing any of the normal adult hemoglobin, but after gene therapy, they are like sickle cell trait. They're producing hemoglobin A, and they have their remaining hemoglobin S. But what's also important is going to show you. So the first part you would see is a person who doesn't have any sickle cell disease. Red blood cells look round, right, normal. A person with sickle cell disease has sickle red blood cells and also normal looking red blood cells. The third one is a person with sickle cell disease who is receiving transfusions. So they have more of the normal looking red blood cells, but they still have their sickle cells in between. If you look at a person with sickle cell trait, right, their red blood cells are round, and they have both hemoglobin A, the adult hemoglobin, and S in all their red blood cells. So after gene therapy, we actually, the patients resemble somebody with sickle cell trait. They have sickle hemoglobin and adult hemoglobin in almost all of their red blood cells. And that's important because we don't want the cells to sickle. This is, showing this in a different way. And this is actually our patient. He's now 3 years post gene therapy. He's graduating from college this year. So the other important part is we looked at the pain intensity in these patients. And both the orange line and the blue line show the pain intensity. Orange was those patients who were having very significant pain, much higher than the population level. And the blue line was they were having better or near population level pain. In both groups, the pain levels decreased by 6 months and stayed there throughout the 2 years. So those are the results from one study. Then I'm going to talk about another study that's ongoing right now. And this actually gene therapy works by increasing fetal hemoglobin level. So fetal hemoglobin is something we are all born with, whether we have sickle cell disease or not. And I'm just gonna jump to this slide and show you, and you still cannot see my arrow, too bad. Can you hear me? Okay. Can you hear me better? Oh, wow. Okay. So when we are first born, we have a high fetal hemoglobin level, and in the first year of life, it goes down to almost non-existent. And then we start making the normal adult hemoglobin, and it goes up in the first year of life. When you have sickle cell disease, again, the fetal hemoglobin goes down, but now the sickle hemoglobin goes up in the first year of life. And that's why we say, usually babies when they're first born with sickle cell disease, they usually do not have pain crisis. We don't see complications of pain crisis till about 6 months of age because they have that high fetal hemoglobin. And then natural history study done showed that people with sickle cell disease, I'm going to turn this off. One second. So I'm not echoing. Adults with sickle cell disease, if they have high fetal hemoglobin levels, they tend to have less problems, less complications due to their sickle cell disease. So that's how the idea came about. If we can increase fetal hemoglobin level by medication, can we change the course of sickle cell disease? And I think there will be a talk about hydroxyurea today, so I'm not going to go into that, but this is doing it with gene therapy. So we have a gene here called BCL11A. And what it does is it blocks the fetal hemoglobin so that you start producing the normal adult hemoglobin. But if we inhibit the inhibitor, bear with me here. So if we block BCL11A, we continue to produce the fetal hemoglobin throughout life. This is what's behind this gene therapy. So we are basically blocking this gene, BCL11A, and these patients start producing hemoglobin F. And this is very similar to the slide I showed you earlier. As you can see, this is months after the infusion, and the blue bars show how much fetal hemoglobin they are producing. They're producing quite a bit of fetal hemoglobin. And this is actually keeping them healthy and preventing complications from happening. So this was on the BBC. This is actually Jimmy who got this gene therapy. And as I'm showing you, the BCL11 gene is turned off, and now his cells have lots of fetal hemoglobin. They are staying round and preventing complications due to sickle cell disease. What most the side effects of gene therapy? You know, everything comes with a price, unfortunately. Most of the side effects that we see are during what we call the engraftment period. So that means we gave you the chemotherapy, we gave you your new cells, but we are waiting for these new cells to grow. So you do not have enough white cells. So you have infections, you have fevers, you can have mouth sores, you can have decreased appetite. All of these happen while you're in the hospital waiting for your new cells to come up. And after your new cells come up, we don't actually see these side effects. But we are more concerned. So these are expected, you know, because we give you chemotherapy, we know it causes these side effects. We see this in any patient who receives this chemotherapy, and we know it's going to go away. But the concerning side effects is, will it have a chronic, long-lasting side effect, the gene therapy, right? So far, there was one sudden death in the study that I mentioned earlier. This sudden death happened in an adult more than 18 months after the person received the gene therapy, and they thought it was probably related to his sickle cell disease, but not related to the gene therapy itself. And then 2 patients developed leukemia. So when patients develop leukemia after gene therapy, the first question everybody asks is, did the gene go and attach itself next to a leukemia gene, and did it turn on the leukemia gene? So they did many studies, and they didn't find any evidence of that. So we know the gene did not do that, but why did that happen? There's also one patient now who developed myelodysplastic syndrome, which is a precursor to leukemia. But so they went back and they looked at one, there are sickle cell patients who can develop leukemia even without any treatment, right? I told you the first transplant was done in an 8-year-old girl who developed leukemia. She had sickle cell disease. We have had patients who had both sickle cell disease and different types of cancer. Right now, we don't have any studies to suggest there's increased leukemia risk if you have sickle cell disease. There is not enough evidence to say that. I'm just repeating. But there are reports of leukemia happening after bone marrow transplant. There are also now reports of leukemia happening after gene therapy. And right now, one of the thoughts is this. Remember, I told you these are bone marrow cells. These bone marrow cells are working very hard. They're working much more than somebody else's bone marrow cells who doesn't have sickle cell disease. And so they're stressed. And then when we do gene therapy, we are actually doing another stress to the cells, right? We are giving medication. We are telling them to come out of the bone marrow. We are sending them to the lab. We are inserting a gene. So the idea right now is that we are probably causing too much stress to the stem cells by this and causing this. But again, I think it's too early to know exactly what's happening. We have to wait and see. More studies have to be done. And these patients, FDA recommended that all the patients who receive gene therapy be followed for 15 years post-treatment. So they are all in a long-term follow-up phase for us to really find out what's happening. It is very encouraging, but we have to learn more. Oops, I'm going backwards. Okay. So if you compare bone marrow transplant to gene therapy, so one of the things that limit transplant is that we don't have donors, right? So we need a donor, whereas for gene therapy, the patient is the donor. So we don't have to wait for anybody. With today's technology, in both situations, the person gets chemotherapy. In the future, this might change if we have some other treatments where we don't have to give chemotherapy. There have been some trials in adults using radiation therapy and bone marrow transplant. To me, that's not that different than chemotherapy per se. With transplant, there is the risk of graft versus host disease, which we don't see with gene therapy so far. We don't have to do immunosuppression with gene therapy, but we have to do it with transplant. And with gene therapy, we need to have more long-term follow-up. So far, we don't have any evidence that the inserted genes are causing the problem, but I think we need to wait more. So again, not enough long-term follow-up. Right now, the gene therapy trials is in the research phase. I just heard that one company just applied to FDA for gene therapy. Gene therapy for thalassemia is actually FDA approved in the United States as of August of last year. But gene therapy for sickle cell disease has not been FDA approved yet. Also, to prepare these cells in the lab takes time. The lab needs about 2 to 3 months. So it's not like, I can do this to 100 patients in a year. It will be, initially especially, it will be a slow process. The gene therapy for the thalassemia treatment, the cost right now is $2.8 million. All right, so there is that part as well. I'm just gonna say it there, but that never stopped us from doing anything for our patients. So we'll keep on fighting. And then the decision to undergo transplant, I say this slide says transplant and it was written for transplant, but it's the same for gene therapy, I think. It's not an easy decision, right? There are many thoughts that go into this. Families have to think of lots of things before deciding to undergo transplant, including will there be a new treatment available, before my child is older? Is there a death risk from transplant or gene therapy? Am I going to get a long-term complication from that? So they all go into the decision. And as was mentioned earlier, unfortunately, mistrust is a barrier to cure as well. There has been, and Dr. Appiah-Kubi is one of the authors of this commentary, but unfortunately, there were terrible experiences in the past. And, we learn from the past. We don't forget the past. But I think we also have to be open. We have to be open with our providers, talk to them, listen to them. Also, we want to hear from you. We want to hear what you want to do. We want to hear what are your concerns, right? And work on this together. So thank you very much. And I think we'll take the questions at the very end.
Thank you, Doctor. Please welcome Dr. Muthu. Dr. John is here to give us a,
On here?
I think, I'm sorry. This is Dr. Ravlin is here. Yeah. Toby John was here. Oh, okay. Thank you for coming, Doctor. Thanks.
Hi, everyone. My name is Ken Ravlin, and I'm a pediatric hematologist. And give me 1 second to pull up my slide presentation. Yes. Oh, no, then please.
I don't.
Sorry, I jumped ahead. John is on.
Hello. Hello. Can you hear me? Hello.
John, the audience can hear you.
Are you able to hear me?
Yes.
Okay. Thank you. I'm having an echo, so I'm just going to mute. I'm going to ask my colleague to mute his speaker. Is that okay? Just bear with me a couple of minutes. Okay. Are you able to hear me now? Hello?
We can hear you.
Okay. Thank you. My name is Dr. Muthu. I am from Kings County Hospital, and I'm in charge of the adult sickle cell program here at Kings County Hospital. Thank you all very much for attending this very important symposium on sickle cell disease, and I thank very much the organizers for inviting me. I apologize sincerely because I could not make it in person, so I'm having to present by Zoom. So I'll start my presentation on clinical trials in sickle cell disease.
We can't hear you anymore. You're muted.
Can you hear me now? Hello?
Yes.
Thank you. Okay. Okay, so let me start from the first slide. My talk is on clinical trials in sickle cell disease. I first wanted to go through the pathophysiology of sickle cell disease, which will help us understand the various drugs and how they work, and the new drugs, which are the putative drugs actually, and their mechanisms of action. Basically, what happens within the red blood cell is actually shown up here on the slide. The cell actually has the hemoglobin molecules, which under certain circumstances, when they have low oxygen content, they polymerize, they form chains. And there are several events which happen within the red blood cell. And
John,
yes,
are you sharing any slides?
I'm hearing you, yes. Can you hear me?
Yes. Well, are you sharing any slides?
You need to share the presentation.
Okay.
You didn't share it.
I didn't share it?
Yeah.
Okay, so.
We'll only see. Is there in the corner? Share.
Share. Not in this one, I think.
Yeah. Share slides.
I think it is on this one. Let me see here. Share.
Yes.
Share screen.
And then you pick
Share
the
screen.
presentation. No, you have to click the presentation. Okay. No, it will show you your presentation. When you say share screen, it should show you this one. And then you just click on it. Then you go to it and share. Again, share screen.
Share screen.
Yeah. You click share here. Then go to my try Microsoft Web Edge. Yeah. Where is the presentation? You see?
I can open up from my email, but it's actually open up on my screen. So I
Yeah,
thought
it's
we can go
supposed
to
to show
entire
share
screen,
screen.
entire screen. Share this.
Okay. So put this one first. Yeah, put this one instead of putting your face. I put this one because it's supposed to actually. Yeah. Okay. Yeah.
Can you see my screen?
No, no.
You can talk from that. I want you to share the screen now.
I'm trying to share the screen, but somehow not able to.
Put it in slideshow first.
Slideshow, okay. Are you able to see the screen?
We only see you.
Yeah. Can we email it to you and then you share it from there?
Can we email it to you?
That's fine. That's fine. That's fine.
Yeah. Send Mr. Vincent. Yeah.
Yeah. Upload it.
Mr. Vincent, I just sent it to you.
Hello? If you look in the chat, just email it to that email address.
It's in chat, but we did send it to.
We sent it to your own email.
Your own email, yeah. It should just need like a minute or so.
Do you see it in your email, sir?
Yeah, and go to chat.
Okay, so this is a different email.
Do you see the email in the chat?
Yeah, I see it.
Is it this one? Okay. Send it now. Yeah, you got it, right?
Do you see it now, Mr. Smith?
One second.
Screen. And then it takes me to this page. It's supposed to show, if I open the screen, it's supposed to take the screen. That is one is right. No, this one is not.
That's already sent.
This is
Is not the correct one?
this is okay. Yes, can you load it now? This is the one.
If you go back to before, go to the WebEx, go to the WebEx. So the WebEx is here. No, the meeting where you're showing the first. There. So if you look, yeah, you can it says we're showing it. Yeah. That's it.
Is that your screen?
Yeah, that's my screen.
You can go ahead and start then.
Okay, thank you. So my talk is on clinical trials in sickle cell disease. I apologize for the delay and with the problem with uploading.
Slideshow. You do with slideshow.
You able to see? Okay. So starting with the pathophysiology of sickle cell disease, this slide is basically to show the pathophysiology of sickle cell disease, which will help us understand how the various drugs work, the ones which are already approved for treatment and the ones which are in trial. So this slide shows basically what happens within the red blood cell with the hemoglobin molecules forming long chains. That's what we call as polymerization. There are several events which happen within the red blood cell, which actually culminate in this hemoglobin polymerization. So there is what we call as spontaneous autooxidation of hemoglobin S with the formation of methemoglobin, and methemoglobin leads to release of free heme within the red blood cell, and the free heme can get externalized and be expressed on the surface of the red blood cell. In addition, the methemoglobin can undergo further oxidation by free oxygen radicals. That is what we call as a pseudoperoxidase cycle, and that leads to formation of certain molecules within the red blood cell. It's actually the feral moiety, which basically causes damage to the red blood cell membrane through formation of certain.
Slide share. It's not showing.
It's not showing.
Slide share. I mean, yeah, slideshow.
Slideshow.
Now it went? Okay, that's fine.
Okay. Sorry, back again. So the important point to remember here is when the red blood cells undergo this change, they become sickle shaped. And when they become sickle shaped, it leads to certain changes within the red blood cell as well as within the blood vessel itself. There is what we call as endothelial activation. The lining of the blood vessels actually gets activated. That is because of release of certain molecules, or expression of certain molecules on the surface of the endothelial cells. And then in addition, there is activation of the white cells as well as the platelets. That's why very often we talk about the role of hydroxyurea, how it actually benefits. In addition to its effect on the hemoglobin F, it also has an effect on this phenomenon of endothelial adhesion. There is also activation of the coagulation cascade because of prothrombinase activation. There is also the inflammatory pathway which is activated because of complement activation, and we will go over that in greater detail in the next slide. So this slide basically shows the pathophysiology of sickle cell disease. So the usual triggers, basically deoxygenation or acidosis or low water content within the red blood cell, which leads to hemoglobin S concentration within the red blood cell. All these phenomena lead to hemoglobin S molecules forming long chains. We call it polymerization. And that phenomenon leads to damage to the red blood cell. The red blood cell becomes rigid, and it also becomes very sticky. And as a consequence of this, the red blood cells actually basically cause damage to the lining of the blood vessel. We call it endothelial damage. In addition, the red blood cells are also very fragile, and they undergo damage and they disintegrate. That's what we call as hemolysis, and that leads to anemia. That's why we see these two things going on together. We see what we call as vasoocclusion, which is blockage of blood flow, and we also see anemia occurring concurrently in these patients. There is activation of the inflammatory pathway, like I mentioned, and the coagulation pathway, and these two together lead to vasoocclusion. The anemia itself, what it causes is it causes tissue hypoxia. Anemia by itself can cause endothelial damage because of high rate of blood flow, and we call it shear stresses on the vessel wall. And together, we get vaso-occlusion, tissue hypoxia together leading to organ damage. The organ damage leads to pain, and the organ damage can lead to death. So this is the mechanism of action of hydroxyurea, and I'm sure Dr. Ravlin will be touching upon this, but I just pointed out this thing, this slide to show the mechanism of action of hydroxyurea. It actually has several mechanisms of action. First and foremost, it can improve red cell hydration. It can induce hemoglobin F levels. And that my colleague actually from Cohen's hospital, she pointed that out, how hydroxyurea downregulates BCL11A, which is a repressor of.
Those the slideshow.
Yes.
Those, do you want to slide that?
What? Okay, so slides are not moving forward?
Yes, slideshow.
Okay.
Yeah.
Okay. Can you see it now?
Yes, it's working.
Thank you. So the hemoglobin F induction, which we were talking about, is because of hydroxyurea downregulating the BCL11A gene. The BCL11A basically is a regulator, which actually affects the HBG gene, which produces fetal hemoglobin. And therefore, we can have an enhanced production of fetal hemoglobin if we can actually downregulate the BCL11A repressor gene, which actually has an effect on the HBG gene, and therefore we can actually prevent the HBG gene from being controlled or repressed. Therefore, we can have an elevated level of hemoglobin F. In addition, hydroxyurea improves the red cell shape, and it also increases nitric oxide, which is an endogenous vasodilator. And it also normalizes the elevated white count and platelets. I wanted to point out a landmark trial, which is the Baby Hug trial with regards to hydroxyurea. It is a pediatric hydroxyurea phase 3 clinical trial. It was a multi-center randomized, double-blind, placebo-controlled clinical trial of hydroxyurea in infants beginning at 9 months of age. What the trial actually showed was low rates of initial and recurrent episodes of pain, dactylitis, acute chest syndrome, hospitalizations, and transfusions. The only things which were noted in terms of side effects were mild myelosuppression, but it was not associated with any increased risk of bacteremia or serious infections. So, although we know that hydroxyurea is an excellent drug and it is still the mainstay of treatment in patients with sickle cell disease, it has its limitations. One of the main limitations is the heterogeneity of the disease. It is a genetic disease, as we know, and there are many different variants like HBSS, HBSC, and so on. There are some types, mild variants, like the HBSC and the HBS beta plus thalassemia, for which the evidence for hydroxyurea is quite weak. There is also heterogeneity of the response. The hemoglobin F level, which we mentioned in the previous slide, and the MCV, which is basically the size of the red blood cell, how it actually changes when the red blood cell gets well hydrated. That improvement varies widely. Some patients don't really have a hemoglobin F or an MCV change, and also it takes considerable time to reach steady state. The third problem with hydroxyurea, which we always see, is, of course, on a day-to-day basis, the maximum tolerated dose which we try to achieve. Unless we achieve a maximum tolerated dose, many patients may not achieve clinical control of their sickle cell disease. They may still continue to have a recurrent pain crisis. That is a very important thing with regards to hydroxyurea treatment, and I'm sure Dr. Ravlin will touch upon that. The absolute neutrophil count of 1,500 to 3,000 units, 3,000 cells, sorry, which is recommended, usually takes 9 to 12 months of treatment. And there is also need to monitor for myelosuppression, as we all normally see in these patients. It has to be done every 2 to 3 monthly basis. So this is a slide to show the mechanism of action of the next main drug, which is L-glutamine. L-glutamine actually has an effect on lowering the oxidative damage to the red blood cell. So there is low glutathione within the sickle red blood cells, and L-glutamine basically leads to formation of glutamate, which is a precursor of glutathione, thereby preventing oxidative damage to the red blood cell. L-glutamine was tested in a phase 3 trial. It is a phase 3 randomized double-blind placebo-controlled trial. It showed decreased frequency of vaso-occlusive crises and hospitalizations, 25% less vaso-occlusive crises and 33% less hospitalizations. It also showed a decreased incidence of acute chest syndrome, but there were no significant difference between the groups in terms of the change in the hemoglobin level, hematocrit level, or the reticulocyte count. So essentially, no difference in the hemolysis marker. So that really creates a doubt and providers like ourselves as to how effective this drug is going to be, although we have some evidence of its benefit clinically. The next main drug which is currently approved for treatment is voxelotor, which is Oxbryta. It is a drug which increases oxygen affinity of hemoglobin S, and it thereby has an impact on all the downstream events, and thereby decreases sickling. With Oxbryta, this is the landmark trial with Oxbryta. Actually, there is another trial which is currently underway, which I will talk about later. The HOPE trial, which is the hemoglobin oxygen affinity modulation to inhibit hemoglobin S polymerization trial. This was a phase 3 randomized double-blind trial. It showed an increase in the total hemoglobin, more than 1 gram in 50% patients, irrespective of hydroxyurea use. In other words, patients who were on hydroxyurea also showed an increase in hemoglobin, in addition to the ones who were just on Oxbryta alone. It showed a decrease in markers of hemolysis like indirect bilirubin and LDH, lactate dehydrogenase. There was a decrease in reticulocyte count. But the important thing to note is there was no difference in the incidence of vaso-occlusive crisis in these patients. There is a study which I mentioned, which is underway to evaluate the effect of the same drug on transcranial Doppler velocity in pediatric patients with sickle cell disease. It's called the HOPE Kids 2, which is ongoing. It is a phase 3 randomized double-blind placebo-controlled study of the same drug in pediatric patients aged 2 to 15 with sickle cell disease. The primary objective is to evaluate the effect of this drug, voxelotor or Oxbryta, on the transcranial Doppler velocity measurements. The fourth main drug which we will talk about is crizanlizumab, and this is a monoclonal antibody to P-selectin, which is a molecule which is expressed on the surface of platelets, like we mentioned earlier in the mechanism or the pathophysiology of sickle cell disease, how P-selectin actually is expressed on the surface of the platelets and the endothelial cells, and it has a role in the vaso-occlusive process. So this study, which is called a SUSTAIN study, a study to assess safety and impact of cell G1 with or without hydroxyurea therapy in sickle cell disease patients with pain crisis. It was a phase 2 double-blind placebo-controlled trial. It showed a 45% reduction in the annualized pain crisis and also a reduction in the length of hospitalization. It also prolonged the median time to first crisis. So it did show significant clinical benefits, but there was no effect on hemolytic variables like hemoglobin, lactate dehydrogenase, reticulocyte count, haptoglobin, or indirect bilirubin. So this again creates doubt in our mind as to how effective this drug is going to be, although it has shown significant clinical benefit. Close in the heels of the phase 2 trial with crizanlizumab came the STAND trial, which was done in Europe. This was a phase 3 randomized double-blind trial. As I mentioned, the previous one was a phase 2, this was a phase 3. And here they had crizanlizumab in 2 doses, 5 milligram per kg per day dose and a 7.5 milligram per kg per day dose. And it was a placebo-controlled trial. Strangely, there was no statistically significant difference in the annualized rates of vaso-occlusive crisis between the groups. So at this point in time, we are not sure how crizanlizumab is going to be used in the future, because we have these 2 conflicting studies. The phase 2 study showing benefit in reduction in pain crisis, and the phase 3 basically contradicting it. So this slide I wanted to show specifically to show the sickle cell life expectancy. Why is it important to do more and more clinical trials in patients with sickle cell disease? So this is the sickle cell life expectancy. And at the bottom I mentioned the current sickle cell life expectancy has improved to 58 years in the US. This is from data in 2014, but there's still a long way to go. And as you can see, the main trials which improved survival in these patients were the transfusion for stroke prevention trials, which I will talk about in a short while. Hydroxyurea certainly has improved survival in these patients. And prior to that, the prophylactic penicillin treatments to prevent deadly pneumonia and meningitis in these patients had a great role to play in improving life expectancy in children. So, is there a need for new treatment options for sickle cell disease? Yes. And as I mentioned here, currently the treatment options target only a certain aspect of the pathophysiology. As I showed earlier, it's a very complex pathophysiology. There are many curative targets which can be targeted to improve or prevent sickling within the blood vessel. So these drugs which we currently have do not address all the manifestations of sickle cell disease. Secondly, there is considerable heterogeneity in the disease manifestations and severity among the different genotypes. There are many different genotypes, some of which are mild, like SC and S beta plus thalassemia, and the disease manifestations vary a lot. And it's difficult to say that hydroxyurea is going to benefit all patients across the globe, as well as other drugs as well. Thirdly, the diagnosis of a vaso-occlusive crisis and its resolution is clinical. There is no biomarker for vaso-occlusive crisis. Number 4, choosing a therapeutic endpoint and determining what change in that endpoint is clinically meaningful is also an important thing. It does not exist at this point so clearly in sickle cell disease as in many other conditions. So I'm showing this slide basically to show the current evidence which we have for the various complications of sickle cell disease, basically enlisting them to show the areas where we have data, where we have evidence and the level of evidence and the strength of recommendations. In crisis, basically there is no evidence for red cell transfusions. If the patients have more than 3 painful crises in a year, hydroxyurea, which we well know, severe symptomatic chronic anemia, hydroxyurea again, and we should be adding oxybryta to this list. Acute chest syndrome, simple RBC transfusions. If it is a rapidly progressive acute chest syndrome, exchange RBC transfusions. If the patient has recurrent or severe acute chest syndrome, hydroxyurea for prevention of future acute chest syndrome is critical. Multi-organ failure, exchange red cell transfusions. For sickle cell nephropathy, just wanted to show that we have no data at this point to show the disease-modifying treatments having a great benefit in reversing kidney damage. We use ACE inhibitors. If the patients have chronic kidney disease and severe anemia from low erythropoietin levels, hydroxyurea in combination with erythropoietin has been shown to have benefit. For acute stroke, exchange red cell transfusions with the goal of bringing the hemoglobin S to less than 30%. For primary stroke prevention, I'm going to talk about these trials in the coming slides. For primary stroke prevention, when someone has abnormal transcranial Doppler velocity, in childhood, ECD velocities are regularly monitored to assess the risk of stroke for kids. And I'm sure Dr. Ravlin will be touching upon that. So simple or exchange RBC transfusions in the STOP 1 and 2 trials have clearly shown benefit. The goal is to maintain the hemoglobin S less than 30%. If the patient is doubly heterozygous like SC, maintain the combined S and C less than 30%. And I'll talk about the TWICH trial switching to hydroxyurea in the primary stroke prevention studies. In the secondary stroke prevention studies, simple or exchange transfusions are again beneficial and clearly has shown a decrease in mortality and morbidity. Maintaining the hemoglobin S less than 30% is again crucial. The switch trial here, switching to hydroxyurea, clearly showed transfusion was superior. For splenic sequestration, simple RBC transfusions. For acute hepatic sequestration, again, simple RBC transfusions, we have evidence for that. For acute intrahepatic cholestasis, exchange RBC transfusions. It's more or less a consensus panel. For priapism, we don't really have a drug which has been proven to be beneficial for priapism per se, although crizanlizumab is in trial for that. As of now, cavernosal aspiration and vasoconstrictor agents are being used along with PDE5 inhibitors. And specifically, there is no evidence for transfusion in patients with priapism. Now, touching upon the stroke prevention trials, the STOP1 trial, which is a stroke prevention trial in sickle cell anemia, STOP1, the incidence of stroke was reduced by 90% in children at high risk for stroke, who were identified by TCD, transcranial Doppler. By periodic RBC transfusions for at least 36 months, a dramatic reduction in stroke was shown. In the STOP2 trial, the discontinuation of red cell transfusion for stroke prevention in children with sickle cell disease actually led to a high rate of reversion to abnormal blood flow velocities on Doppler studies and stroke. So for stroke, both primary prevention as well as for secondary prevention, there is clear evidence for red cell transfusions. Now, how long can we keep these patients on transfusion has always been the question. Chronic transfusion followed by transition to hydroxyurea has always been debated a lot. We have two trials in this regard, one called the switch trial, stroke with transfusions changing to hydroxyurea. This is for secondary stroke prevention for children with sickle cell anemia, stroke and iron overload. Transfusions combined with chelation was found to be superior to hydroxyurea combined with phlebotomy. In patients for primary stroke prevention in children, this was called a TWITCH trial, TCD with transfusions changing to hydroxyurea. For primary stroke prophylaxis, hydroxyurea was shown to be non-inferior to RBC transfusions for primary outcome of transcranial Doppler at 24 months. So hydroxyurea could be used for primary prophylaxis, and it was shown to be non-inferior to red cell transfusions. Just wanted to touch upon the TAP study, which is a transfusion alternatives preoperatively in sickle cell disease. This study was actually a landmark trial. We always have this question to answer as to whether we should transfuse patients preoperatively if they're going in for a surgical procedure. The study was not a big study. It was only done with about 35 patients in each arm, the no transfusion arm and the transfusion arm. And clearly the no transfusion arm had significantly higher perioperative complications, including acute chest syndrome. So clearly there is a role for preoperative transfusions. And we always recommend that for all our patients going in for especially high-risk procedures like joint replacement surgery where there is going to be a lot of tissue damage and prolonged general anesthesia. I wanted to touch upon a specific trial which we have done here at Kings County Hospital. The drug was codenamed Sickle Cell Disease 101, SCD-101. It was tested in sickle cell anemia, that is SS, and sickle beta zero thalassemia patients. And it was a phase 1 study. It had two parts, an open label dose escalation study and part B, which was a randomized placebo-controlled crossover cohort study. And we were able to show that this drug, which basically is a botanical, which is extracted from the leaves of a plant called sorghum, the medication was found to be safe and well tolerated. It reduces pain and fatigue and improves red blood cell shape. And this is the slide basically to show the improvement in the fatigue scores. We use the PROMIS fatigue scores to show with various doses, we found that there was an improvement. With higher the dose, the better the improvement in the fatigue. Specifically in cohort 4, which was 4,400 milligrams twice a day dose, we clearly saw there was an improvement in the fatigue. And then we also saw an improvement in the patient-reported bone pain. So most patients, as you can see, especially in the higher cohort levels, actually cohort 4 and 4R, we saw that the pain was significantly lower, especially as the patients took the drug for about 29 to 35 days. That was when we saw the clear benefit. So this is basically to show how well this drug was tolerated. This drug was fairly well tolerated. Some patients had pain, which could have been part and parcel of their sickle cell disease itself. By and large, the drug was very well tolerated. A few patients had headache and a few had GI disturbances, but overall very well tolerated. And this is a slide to show the in vitro activity of this drug, to show that it has in vitro anti-sickling activity. And this is another slide to show the mouse model. Transgenic sickle cell mice, when treated with this particular drug, actually they survive very well. And at autopsy, we could show very clearly the untreated mice compared to the treated mice. Untreated mice had significant damage to their lungs, significant congestive changes in the lungs because of vaso-occlusion. And this is a slide to show the anti-sickling effect of this drug, CD101, at baseline at day 28. And as the drug was stopped, we could see the change in the cells back. They revert back to their sickle shape. The next thing which I wanted to talk about specifically was this pyruvate kinase activator. It is currently actually in trial at various health and hospital sites, including ours. It has a name, it's called Appiah-Kubi. It's a phase 2/3 randomized double-blind placebo-controlled 52-week trial where participants will receive either the investigational drug or placebo. The investigational drug is given in 2 doses, 200 milligram a day and 400 milligram per day doses. And patients could also be on a placebo, so it is a 3-arm study. At the end of the 52-week period, patients have the option to go on to open label extension study period, where all the participants, including the ones who are on the placebo, will receive the investigational medication. The interim analysis has been done and it has received continued FDA approval for the study. And this slide is actually borrowed from the pharmaceutical company marketing this drug, Pharma Therapeutics. And this is basically to show the mechanism of action of Appiah-Kubi, which is a pyruvate kinase activator. It has 2 mechanisms of action, basically. One, it is a pyruvate kinase activator. It leads to decreased 2,3-DPG, which basically is the molecule which enhances oxygen release from the hemoglobin molecule. So if you actually decrease the 2,3-DPG, you can actually enhance basically the oxygen affinity to hemoglobin, leading to higher oxygen content within the hemoglobin. And as the cells actually travel, they're able to deliver more oxygen to the tissues. It also has another action on enhancing ATP levels, which actually benefits the red cell membrane integrity. The red cell membranes are having better integrity because of high ATP levels. The next study which I wanted to point out specifically was a phase 2 randomized double-blind placebo-controlled trial to test rifaximin. Rifaximin basically is an antibiotic and it is used for various conditions. This particular drug, there is concept of proof. This study, which was basically published by Dr. Lim, who was a former colleague of ours at State University Hospital, downstate Brooklyn, he basically showed that translocation of intestinal bacteria into systemic circulation led to increased circulating aged neutrophils in sickle cell disease. And intestinal microbial modulation can lead to a reduction in vaso-occlusive crisis. So this study is currently recruiting at Kings County Hospital. I want to touch upon a few other trials which are of note because the mechanism of action seems to be very promising and there is proof of concept in these cases. So this particular study, the drug IMR 687, tovinotrin, which is a highly selective phosphodiesterase 9 inhibitor, and it has been published already. It's a long-term phase 2A open label extension study given either as monotherapy or in combination with hydroxyurea in a dose of 200 milligram a day. And it leads to increased cGMP levels, which leads to increased fetal hemoglobin expression, reduced hemolysis, and sickling of red blood cells. So a phase 2B study to further explore higher doses like 400 milligram a day as disease-modifying therapy is actually in the cards. Then we have the FTX 6058 study. Basically, it's a fetal hemoglobin F inducer. It's a phase 1B trial, which actually showed that FTX 6058 actually works on BCL11A, which we already talked about. thereby causing an increase in fetal hemoglobin level. It has favorable safety and profile, and also dose-dependent increase in HBG mRNA. HBG is a gene which produces fetal hemoglobin. Study is currently on clinical hold by FDA. The next study which I will touch upon is the study called Vision Serenity. It's a study to assess efficacy and safety of VIT-2763, a drug by name Vanifort in patients with sickle cell disease. Ferroportin, it's a ferroportin inhibitor. Ferroportin basically is a molecule which transports iron, and this is an inhibitor of that molecule, which thereby leads to decreased iron-restricted erythropoiesis, which basically means decreased red cell production driven by iron, which lead to a decrease in the red cell damage and breakdown of red cells in the Townes model of sickle cell disease. Townes model is a mouse model of sickle cell disease. And it also showed a decrease in VCAM1, vascular cell adhesion molecule 1 concentration, which leads to decreased vascular inflammation and decreased adhesion of red cells to the endothelium. So in conclusion, I would like to say that there is access to clinical trials for patients, and I would encourage patients to access the clinicaltrials.gov website. And feel free to ask any questions, and I'm open to questions.
Just want to say thank you to the doctor for making the time for us today. Thank you so much, doctor. Hope you can hear us. Thank you so much. We have Dr. Ravlin next.
Thank you. John. Can you hear me? Sorry. Into the mic. What I wanted to start with, this is such an exciting time for potential for sickle cell disease. I've never been more excited. We are actually Is this okay? Thank you. So let me try again. Exciting time for sickle cell disease. We have just heard about curative therapy. For the first time we can cure sickle cell disease. Just blows me away. The other thing is we have in the pipeline of all the work that John was talking about, a lot of drugs that are going to modify sickle cell disease over time. If you look at my pictures, let me put this on slideshow. Okay, if you look at this, these are two molecules of hemoglobin. Do we have a pointer here? Sorry. No, okay. That's good enough, yeah. So if you look at the picture of the two round balls, those are two deoxyhemoglobin molecules sticking together. The picture that's in gray color is actually the polymerization of those molecules, forming chains, forming crystals that is breaking apart a red blood cell. And the bottom picture is a picture of just what sickle cells, a smear of hemoglobin, a smear from a patient with sickle cell disease. We heard earlier in the day about all the complications that come because of these factors, the polymerization of the hemoglobin, the sickling of the red blood cell, the sticking of it to the blood vessels, causing everything from pain to the potential for stroke. What I don't think most people in the general population know is what it's like to live with sickle cell disease. I'm a hematologist oncologist, and I think most of the general population knows what it's like to have a relative go through chemotherapy, have cancer, be diagnosed, and be undergoing active chemotherapy. The life of a typical patient today with sickle cell disease, anyone in the audience that has sickle cell disease, is worse than that patient who's actively undergoing chemotherapy. That just blows me away. When I think about pain, it's worse than a heart attack. It's worse than a broken hip. It's worse than a contraction during childbirth, which many women can experience that pain. It's just a horrible, horrible disease. And we can begin not just to provide pain medication, we can begin to treat this disease. What I want to do very quickly, and I won't tie you up with a lot of details, is I want to review the pathophysiology that John just went over. I want to talk a little bit about the current and future targets for therapies for sickle cell disease. Again, you just heard an excellent talk about that. And I want to highlight the importance of it's not just having therapy that's critical to improve sickle cell care. It's actually getting the patients to utilize this. So let's just imagine for a second, you have a disease that's complicated by pain, can affect any organ in the body, and you have a drug that can decrease this, that can modify it. And only about half of the people use it. That's hydroxyurea. And that's something that we need to work on as a community to increase its use. So the question that we need to do is how can we increase its utilization? And I want to just tag about 5 minutes at the end of this talk about what we're doing to try to improve it. Sickle cell disease, by the numbers, about 100,000 people in the United States. Every year, about 250 newborns are diagnosed with sickle cell disease through newborn screening. The prevalence in New York is between 9,000 and 10,000 individuals. At Health and Hospital Corporation, we see about 2,500 individuals with sickle cell disease touch our system in a year. We treat with consistent care about 1,000 adults and about 500 children. We're taking a great proportion of that. So what we're doing here really has a chance to impact it, just like LIJ. We heard about prevention of infections, education, stroke prevention, disease-modifying therapies. The gold standard is hydroxyurea. You heard about Exbrita. You heard about Priz, and you heard about Eldari. And you heard about the curative therapy that's so exciting, that's potential out there, is gene therapy, gene editing, bone marrow transplant. This is the pathophysiology that John was talking. There are 4 key components of how sickle cell disease causes problems. One is this polymerization. Bone marrow transplant stops that by changing the gene, replacing the abnormal cell. Hydroxyurea works by increasing non-sticky hemoglobin molecules so they can't stick together. Some molecules, small molecules that are undergoing clinical trial are supporting the repair of the red blood cell membrane so that they don't break apart. There are some other drugs besides hydroxyurea that are increasing the production of fetal hemoglobin. Again, you can decrease that polymerization and the sticky. The other part is there's vasoocclusion. You're dealing with cells that stick to the endothelium, to the blood vessel lining, cause obstruction. We are developing drugs. There's a group of Priz is a drug that blocks the adhesion of neutrophils to those blood vessel walls, decreasing the opportunity to cause blockage of blood vessels. A major problem with sickle cell disease is it causes sterile inflammation in the blood vessels. And if we can work on decreasing that with decreasing neutrophil thrombin deposition, we can decrease sickling crises. And finally, free hemoglobin affects dilatation of the blood vessel. If we use drugs like Eldari that stimulate nitric oxide, we can improve dilatation of blood vessels and decreasing sickling. We have a lot of different targets to address. I want to just, you heard all these clinical trials through John. I just want to highlight hydroxyurea. That's our gold standard, and it's being underutilized. And we as a community need to work together on increasing its utilization. Hydroxyurea works at all the 4 components that cause disease. So it decreases polymerization by increasing fetal hemoglobin. It decreases the number of sticky cells. Sticky cells are neutrophils, they're reticulocytes. It lowers that. It improves endothelial function by decreasing this intravascular hemolysis. It also decreases that sterile inflammation that is causing damage throughout the body. Blood vessels. It's now considered the standard of care for the 2 severe versions of sickle cell disease. those with hemoglobin SS or S-beta thal 0. Those are the most severe. It works in the other type, but we don't have good clinical data. For SC disease, we have a lot of anecdotal evidence that it works. We also have been using these drugs for the last 30 years, and we know it's associated with decreased painful events. We know it's associated with decreasing mortality, improving quality of life, improving growth and development, normalizing sexual maturation, decreasing organ death. It's a great drug. We believe the earlier we start, the less organ damage that goes on. Our current goal is to start it by 9 months of age in the people with the worst phenotype, SS, S-beta thal. These are the clinical trials that John talked about. First clinical trial was in 1984. The first major clinical trial was in 1995. We've used in pediatric the turn of the century. The first major phase 3 trial in children showed that it was effective in decreasing pain, hospitalizations, swelling of the hands, damage to the lung. In 2015, there was a switch study which showed that it decreased stroke. So it's a great drug. We know it decreases symptoms, improves quality of life, improves academic performance. It's not used. In New York State, when we look at the recent data, it's used in about 50% of eligible patients. That's not good enough. At our system, we started a grant looking to improve the utilization of hydroxyurea by using a shared mental model. An ED doctor, you see an ED doctor and you're coming in with a vaso-occlusive crisis, they're going to talk to you about, are you on hydroxyurea? How they're seeing less patients that are on hydroxyurea. They're going to give you a story that's going to support it. If you see your pediatrician or your internist, they're going to talk about hydroxyurea making a difference in someone's life. You see your hematologist, we're going to talk about it. If you don't believe us, we're going to connect you to community health workers. We're going to connect you to community-based organizations like this organization. Talk about hydroxyurea and its impact. We want to also, as a provider in a city hospital, we have lots of different people taking care of you. We want to encourage best practices by standardizing our documentation. So one of the big things we did was create standardized documentation for sickle cell disease in Appiah. So that's the exciting things that's going on. We're actually changing the quality. Yes. I'm interested, I do sickle cell work because I saw the tremendous disparity in care between my oncology patient and my sickle cell. And it would break my heart. And it wasn't because of an intrinsic bias, it was because of urgency. An oncology patient is more urgent. When they're in the clinic, and they have fever and neutropenia, they're going to take priority over a sickle cell patient in pain. Breaks my heart to see that disparity. The way we can eliminate disparities in care is by changing the quality of the care, and that is quality improvement. And that's what we've been doing at Health and Health. We're working on eliminating disparities by improving the quality of care. For hydroxyurea, it's this shared mental model. We're going to support you. We're going to make sure if you're not used to treating sickle cell disease, you need that bucket or box where you can't progress in the medical record. And this is the key components. So I have a few slides on why hydroxyurea is important, what families want to know. The big thing I want people to take away with one pain crisis is too much. It's a representation of damage going on to the body. Let's use hydroxyurea before pain starts. We want families to know that the short-term side effects are real, but we'll monitor them. The long-term side effects tend to be theoretical. There was a theoretical risk for cancer. Probably not true. We have not found it, and we've studied this as a major point for the 30 years of using hydroxyurea. People worry about hydroxyurea and fertility. And though it can decrease sperm count, we haven't seen the evidence that long-term use decreases fertility for both men and women. And we have no evidence. People were worried about what happens if I get pregnant when I'm on hydroxyurea. We want you to stop taking the hydroxyurea, but we found no evidence that it ever causes birth. The pros of hydroxyurea is patients have higher hemoglobin, they have more energy, improved appetite, normalizes weight gain, reduces ED visits, hospitalizations, missed days from work, missed days from school, and you have a better quality of life. The cons for taking hydroxyurea is you have to take a medicine every day. That's not fun. Every time you take a medicine, it reminds you I'm different. But it's important to do. And you require more blood tests for monitoring. This is the video if you want. If you just Google Jacobi Hospital, which is my home base, and hydroxyurea or this website, there's a nice YouTube video of patients discussing how hydroxyurea has improved their quality of life. So from pediatrics to adults, it makes a difference. And I'll stop here. Questions and lunch. So, thank you.
Thank you, thank you. Well, we have a 15, 30 minutes break for lunch. So, please, you can get up your seat, relax, make friends, talk to each other, say hi to the doctors. And then, of course, later on, we have question and answers, and you'll be able to ask your questions later on. Thank you, thank you.
I'm out.
Thank you.
All right. No. Dr. Aygun, you want to take one? All right, fine.
Get him after his talk.
Okay, thank you. Thank you. Thank you.
Move into
Thank you.
Right there.
Look, you did it again. Come on, you.
There you go.
Like that lovebird.
It is.
Thank you, Doctor.
Hello. Hopefully it works. I'm not having an echo. That's good. Hi. I must say good afternoon. Most of you, I know most of you here, but I'm Dr. Pollard. I'm not a hematologist, pediatrician, so that I'm a surgeon. And that's why I'm involved in this. Having been at Queens for the past 40 years and having witnessed how patients with sickle cell disease used to be cared for, I think that has motivated us to find ways for patients to be treated better, to really people understanding them better. And I've been really blessed to be at this institution where this has been taken seriously by our leadership, by our elected officials, by our clinicians, and by our community that has really been put together to make life of our brothers and sisters in the community better. And I'm extremely happy to be here. I also want to thank the Sickle Cell Awareness Foundation for putting these events together, and for all our partners, the blood bank, our elected officials again. We listened to some wonderful presentation this morning that give us tremendous hope and pride on the work that we have done and continue to do. And I'm really, just like Dr. Ravlin says, excited about the time that we are in terms of how we're going to be able to help our brothers and sisters better with the communion of all of us, focusing on getting better treatment, better care, better understanding, and a more humane approach to patients and individual and their family with sickle cell disease. So I've been asked to moderate this panel, and I would start by thanking the panelists for their presentations. Have been wonderful. I have learned a tremendous amount this morning. And I don't know, I'm sure that you have also. And I also appreciate the commitment of the people that have presented this morning, because they've been at this for a long time. And I can say it's a labor of love. So I'll start by one of the things that we at Queens, we do have this grant that we're working on for the sickle cell, or that hydroxyurea. And we find that it's not financial incentive that makes people prescribe hydroxyurea. If it was, we would have 100%. I think it's just something deeper. And I said I always tell my folks that there is motivation and there is inspiration. It's the inspiration that you're doing something that is going to be after you're gone for a long time, that's still there. And that's what motivates a lot of us to work in this field. So I would ask Dr. Ravlin to tell us a little bit about the research itself, how it is going. Hopefully we'll try to limit the time that we take to answer to about 2 minutes, and then we can have follow-up questions. That way everybody has a chance to say something, to ask questions, and have their answers. Dr. Ravlin, I'll start with you.
Thank you. The research that we're doing with regards to increasing hydroxyurea has actually been very successful. Queens had a high start point. They had about 60% acceptance in eligible patients, and they're now in the high 70s. So very exciting to see what a dedicated group of people Queens can do. The grant was designed around the concept that incentives will make a difference. What we're finding is it doesn't hurt, but the real thing is building the infrastructure that makes your life easy as a doctor to provide care. So to have all the information in the electronic medical record that you need is right there. It forces you to check boxes, to ask the patient, to refer the patient. That's the infrastructure that makes life easier. And that's, I think, what most of us are feeling is making a difference, that we have a common goal. So ED doctors, pediatricians, hematologists, community-based organizations, Salma here, the community health worker, we're all on the same page. We're all trying to do the same thing.
Is there any questions from the audience? I don't want to be the one asking questions. Come on. Don't be shy.
Yes, on now.
Good afternoon, everyone. My name is Carlene, and I am also a sickle cell patient. I don't have SS, I have sickle thalassemia. So I just wanted to know from the doctors, in your experience, do you get a lot of patients that has sickle thalassemia, and are they taking the hydroxyurea, and what kind of symptoms do they experience being on it? Do you find that it's helpful for them as well, or just for people with SS or SC?
There are two types of sickle beta thalassemia. There's 0 and there's plus. All patients with 0, all children, pediatrics, my field, all children 9 months of age and above should be on hydroxyurea. The problem with thalassemia plus, the problem with hemoglobin SC is we don't have randomized clinical trials. So most of us put people on it on a case-by-case basis. So if you're having evidence of vasoconstriction, if you have abnormal transcranial dot, you have any abnormal finding, we're more likely.
Okay. I asked because I think I was around 29 when they started me on the hydroxyurea. A few months later, I had to get off of it because I had a brain aneurysm. So thankfully, I'm here. I was able to survive that aneurysm. And then now, recently, I was told that I have 2 more aneurysms in my brain, and they're thinking that I need to do surgery. But I'm a little bit undecided about the surgery because of the risk, because the first surgeon that did the previous one, he didn't want to touch the 2 new ones. And then this other, I went and get a second opinion, and they think I should do stent. But I haven't been on the hydroxyurea since last August because the doctors took me off of it because I was also having an issue with the ulcer, and they thought it was not going to heal if I continued to take it, because that's one of the side effects, if I'm not mistaken. So I haven't been back on it, and as a result, have gotten more sick each time, not being on any medication during this process because of the ulcer. So I had to be transfused quite often, more than I ever have in my entire 45 years. The last 5 months have been really bad when it comes to my sickle cell. I don't get a lot of pain crisis like most sickle cell patients. I struggle with breathing issue. I get a lot of respiratory problems because of the cell. So I'm just a little concerned. What kind of advice would you give me who don't have SS, which the drug really helps, but the drug helps me, but then there's those other issues that I have after.
I don't want to give specific advice in a general meeting. So I'm happy to talk to you afterwards. We talk about it.
But I do have to say, I don't think hydroxyurea causes leg ulcers, because we actually have patients who have been put on hydroxyurea when they had leg ulcers, and we've seen the leg ulcers heal. We also have patients who were on hydroxyurea and got leg ulcers, and then we just maximized their therapy by, for like 1 week, this is just general stuff, right? Don't take this, but for like 1 week added voxelotor, and on the combination, the leg ulcer healed. And so there are so many complications from sickle cell disease, and it's not one thing fixes everything. Short of transplantation or gene therapy, I think the next best thing we honestly have would be transfusions. And so we go to that frequently when our other disease modifying therapies don't seem to get the job done. And we have several individuals that we place on transfusion therapy, be it simple, where we just give you the blood, or exchange, where we remove your sickle cells and give you non-sickled blood. And you look amazing.
And I'm going to add one other point as both of the doctors here were talking. Definitely hydroxyurea is the gold standard. It's our first medication that we offer to any patient. But I think we are realizing that now we have the availability of newer medications that work through different mechanisms. So we are going towards more and more what we call combination treatment because, as we said, hydroxyurea is good to prevent so many different problems that we see in sickle cell disease, but not 100%, right? So we may need to add another medication to prevent that certain complication.
What I'd like to add too, I see I'm here at Queens. I'm the research nurse manager here. I have just recently gotten involved in the past couple of years with sickle cell patients, but I have worked for the past 20 years on cancer patients. And before that, I worked in pediatric with other inherited diseases and clinical trials. And when you look at this, it took a long time to even develop hydroxyurea, 100 years to develop a medication to treat you. We're now at the point where we're having symposiums to look at new medications, to raise awareness of clinical trials. And, I just want to highlight that sometimes, the standard of care now, we only have a handful of medications that are approved. We have a whole bunch that I'm sure talked about. I wasn't here at the beginning part of the lecture that are in clinical trials now. I know everyone on this panel has access to looking for clinical trials, for you. I don't know what hospital you're at, but really everyone in the audience, one of the things you should come out of this symposium with is opening up our minds to that we're looking at the different mechanisms of action of how to treat sickle cell disease. And in that, looking at it, we're going to develop new medications to do so. So I want to make sure that everyone really has an open mind to clinical trials and that may be an option for you when standard of care doesn't work. And like Dr. Ravlin said, for your disease, there's not that many patients that are studied in it. We have to change that and get to that. And anyone's welcome to talk to me and we can go through some trials. And whether it's here at Queens or whether it's at Jacobi, we all work together to make sure that we give the patients the best care no matter where it is. And we talk to them about it. And so I want to just make sure that people open their minds up to not even just the treatments of today, but the treatments of tomorrow.
Thank you for your information. Regarding the study of the hydroxyurea, I was wondering, since it's such a powerful drug, how is it that it's not so readily available to the sickle cell patients? Is it a matter of insurance qualifying them, or what is the problem?
It is readily available. So there's it's not an expensive medication. It's readily available. We want patients to go on it. There should never be an insurance reason
Not an
to be
insurance
placed
issue.
on it. So
That's good to know.
what it is the community, right? So a lot of people will go, it's a drug that was used to treat cancer. It's not a good cancer drug. But why would I go on a drug that wasn't designed for my sickle cell disease? My response to that is there are a lot of drugs out there that we use all the time that weren't designed for what they're being used for. I think the two classic ones are minoxidil for growing hair, right? It was hypertensive blood medication that had a side effect of growing hair that made it unusable for people with hypertension. And the other one is Viagra. It was also a blood pressure medicine that caused certain side effects that prevented you from from it being used in the general population. Okay,
Thank
so we need to talk to each other in the community, make sure it's
Get
used
the
more
word out.
regularly.
Thank you so much.
My name is Romain Saunders. I have sickle cell, as you know, SS disease. I have priapism and everything. So Dr. Toro and all you guys helped me to come back from my sickness. From I start taking the medication, Ijoxuria, it's helping me a lot, but there's a trick to it. You have to take it on time and the perfect time. Yes. Yeah, and you best time to take it is before you go to sleep. As you go into sleep, you can take it. Because yeah, but it don't work for every and anybody. So the blood is it's the cause of the blood. So it don't work for every and anybody. So you guys gonna change or do something about that. But I just wanted you to know, like it's helping me to cure my sickness. Yes.
I love what you said. You have to take it. I mean, you have a way to take it, but just taking it is step one. So the barriers, one, yes, community. Then two, you get it prescribed. There's a question right here. Lady. And then three is actually taking it. And I think that's a barrier as well, because just because I prescribed it doesn't mean it's being taken.
My daughter is 55. She's had 3 strokes. Had a replacement right hip, replacement right shoulder, replacement left shoulder. She's on Syria, and she's doing well now. But she also is on reverse transfusion, and every month she has a transfusion that worked well. But last month they took out 6 bags and put in 6 bags. But the question is, why did her hemoglobin number go down? And she received good 6 bags. And that was, they didn't understand that because it usually a little better after the transfusion. But this time, they took off 6 bags and put on 6 bags, born in New York Hospital on 68th Street in York Avenue. And that's where the hematologist is. And I was wondering if you have an adult hematologist here, because it would be closer for me because I'm in Brooklyn, and New York Hospital is an hour and a half away. When she's in crisis, that's a lot of time. So is there a doctor here for adult?
Don't turn around.
Okay, thank you. Thank you.
Make sure you go get it.
All right. Thank you so much. No, I want to mention, so unfortunately, the New York greater right here. Need those things. So the other word, spread in the community is also having plans that many people know that telephone echoes.
I want to make one comment. There are ethnic variations, but your population, New York blood center, blood, Black American, Hispanic, need blood first. So, the Pokemon takes very little to donate blood.
Yeah, I forgot to mention this. I have sickle cell and stroke. So it's about the blood, how the blood works, and I have over 100 blood transfusion, so I can't get any more, no matter what. So I gotta take care of my body and watch myself, so I don't get any overloads and every overload. Yes, so I gotta watch my body. So I have to take the Ijuxuria to lower everything in my body. So Dr. Tora is guiding me on the right track. So everything is good. So everything is good right now. So, yeah.
The question in the back.
Hi, everyone. I'm a nurse practitioner and I work with Dr. Ravlin and Francisco at Jacobi. The thing that, and I started working with Arturo 6 years ago. So he's been around in Queens for a long time. I think what we have developed, Arturo has a monthly support group meeting the last Wednesday of the month from 1:30 to 2:30. Candace Sickle Cell Fund has one on the first Tuesday evening from 6 to 7. SCTPN has a Saturday morning, 11:30 to 12:30 community connections looking at the care of people living with sickle cells, not just here in New York, but around the world. So breaking down the barriers where we can come together to push for healthcare change. And that's been part of the grant that looking to put protocols for pain management in the ED. So if we all work together, whether you're in Brooklyn or Rochester or Albany, is to create a greater community so we can push the healthcare system for the changes that you all need and we want to give you. And if you want some information about this community-based organization, I'd be glad to share that with you. Thank you.
Thank you, Tony. Any more questions?
Yeah. So I usually be in the hospital a lot before I start taking the Ijuxuria. And I start taking the Ijuxuria, everything just calmed down. And I usually be in the hospital a lot, like every year and every 3 months. So no, I'm not in there like for like 2 years now. Yes.
Any more questions?
Can you tell us a little bit about, is there a relationship between cancer and sickle cell? And can you, I mean, when you look at a sickle cell, person with sickle cell, you really can't tell. Most of the time they look normal, look like us, and why is this disease so pernicious? Can you break it down for us? QB?
I gotta break it up. The first part was
Oh, and cancer. I think it was mentioned in a few of the talks today that we have not found a direct correlation between sickle cell and cancer. And as Dr. Aygun showed in her talk, it was a sickle cell individual who happened to have cancer and got transplanted and got cured of both diseases. So sickle cell individuals are at risk of getting cancer like everybody else. Just because you have sickle cell doesn't mean that you can't get cancer. And just because you have sickle cell doesn't mean that you will get cancer. But the risk is the same as the general population, based on the information that we have as of now. Well,
So in addition, I think being get
very, very good point. And then the comment slash question about them looking like everyone else, I think that is part of the problem. See, it's a blood disorder, and your blood isn't normally visible to anyone unless if, get cut or something. But the havoc that it's causing is literally from head to toe, because it's every single organ in your body needs blood. So everything is affected. Unless if, someone has a stroke and it has some debilitating effects, so you can visibly see that. But I think that is actually part of the main problem, the fact that most people don't show any evidence of having any major problem. And that's what leads to many of the mistrust and I don't know what other words to use to describe it, but it's hard for people to believe you when you're describing something to them and they can't see any evidence of what's going on. So I think events like this will hopefully help change that.
Yeah, I was also going to say that there is not enough public awareness of sickle cell disease. That's also part of the problem. So people don't know what it is. People don't know how it affects your body. And there are no physical signs that you see from outside. So, okay, I don't know, sickle cell disease cold or we have had patients who were asked like, how long have you had it? Like, and they're like, I'm born with it. But people don't even know that part. So, so I think we have lots of work to do on all of our parts to raise awareness.
On the same topic, I think most of you have heard of the disease cystic fibrosis, right? It's popular. Most Americans have heard that term. Sickle cell disease is three times more prevalent than cystic fibrosis. About 30,000 people in the country with cystic fibrosis. It gets hundreds of millions of dollars in funding. Its community-based organization is one of the best funded organizations in the country for a disease. Yet, sickle cell disease has always been a low priority. And part of it is because of who it affects. One's a disease of Caucasians, and they're both genetic diseases. And one is a disease of African Americans, Hispanics, people of Mediterranean descent, and India. So it's a very different disease. We need to prioritize it. We need to sit there and talk about health equity. These are things that we can't be silent about. We were talking before about trying to get World Sickle Cell Day is June 19th. People have tried to get the Empire State Building lit up in red for World Sickle Cell Day. They said, no, these are things that we need to continue to advocate for. And that's what this organization's been doing for a long, long time.
talking about sickle cell on my radio show every week, trying to engage the communities about sickle cell. So, you know, I am trying to spread the word as much as I can. And I hope in the future to have some of you doctors on my show to bring more light to it, if you can enlighten us and help us understand it. But my question is, Dr. Kubi, you mentioned in your presentation that malaria, if you're in an area, if someone, and it had me thinking, is if you're in an area where you got malaria and then later on in life you get sick, how does sickle cell start? You could get it from malaria or in.
Okay. All right. Thank you for the question. So, there's this thing called natural selection where certain diseases happen and certain individuals who can survive that are the ones that live and, continue the generations. So in areas that are endemic with malaria, it just so happens that individuals who have the sickle cell trait actually thrive better. If you have the disease, it's actually really bad. But if you have the trait, the parasite can't really thrive in you as well. And so those individuals happen to survive. And so they reproduced, and that's how it's been there for all these years. There's an initial mutation that happened many, many years ago. But the reason why it keeps going is because in areas that are endemic with malaria, individuals who have sickle cell trait actually thrive better.
My first question is, with sickle cell crisis and sickle cell trait, do they experience the same type of discomfort and pain, or the sickle cell trait does not experience any pain?
Do not currently believe that sickle cell trait has pain crises in normal conditions. So at the extremes of life, you can have a sickle cell crisis type pain or a sickling event in extremes at high altitudes, deep sea diving, climbing Mount Everest. We have one of our attendings at Mount Everest right now here, and if she had sickle cell trait, she would have difficulty surviving at that altitude. She would have crises. So it's the extremes of life that we worry about traits. The pain crisis for sickle cell disease is different. And it's devastatingly painful. You can think about it like being a heart attack of your entire body.
Thing is, I think you're absolutely correct. When it comes to education, education is a big factor, because as I'm listening to you talk, you're saying it's mostly in the Black communities. Well, I'm here to tell you that with the mixed marriages now, it's going out. And I am seeing it in Chinese. I'm seeing it in white people. They're telling me they have sickle cell. Really? Okay, yes, my husband is Black. We had these kids. And so, yes, it is getting out. It's just more than just the dark skin community or the Hispanic community, because we're becoming interracial.
History of sickle cell disease follows wherever malaria falciparins, a type of severe malaria, is found. So you're going to find a high level of sickle cell disease, not related to intermarriage, in people of Greek and Italian descent. So in that area, because of malaria falciparins. And today we should never be doing racial-based screening for a disease. Race has no biological meaning. And so it's just something that we all need to recognize. It should never be done. Race is a social construct. It's not a biological construct.
How the sickle cell disease is created, it takes two traits to make one disease. So my mom's and my dad have the trait, and I was born with the disease. So yeah, that's how it came along. And trait don't feel much pain as the disease. As you quint, we are in pain, and I never hear my mom suffer from like cry out for pain, and so that's different.
Hello, thank you. As a mom with a son with sickle cell, what can we do for there to be more funding towards this type of chronic illness?
Can you hear me? Okay, thank you for the question. Yeah, so what happened with cystic fibrosis is actually it's the parents who went to the Senate. So it's the community that got together. It wasn't the physicians, it wasn't the medical professionals, it was actually the families. So I think, I know your voice is much more powerful than my voice. Okay, so trust that, believe in that, get together. There are organizations, right? There is like this one, right? There are other community-based organizations throughout United States. There is SCDAA, Sickle Cell Disease Association of America. Also, American Society of Hematology, and Dr. Ravlin, mentioned that earlier as well as you did, that they are now putting together a clinical trials network, and as part of the clinical trials network, they want to hear from the community. They have community-based organizations throughout the country, and they want to hear from people living with sickle cell disease what's the most important research for them. Okay, so please join those organizations and make your voice heard.
I may add, and that now is from the Health and Service Office. I know. Health. Funding that's available because the eyes have been focused on that because of all the disparities came up during COVID to see whether you live where you are, what you look like, made a big difference in terms of your mortality to COVID. And that was everybody saw that. Nobody could hide and said things were not different in the community. So that's why there is an emphasis now to put some funding available, and the OMH, Office of Minority Health, has been there encouraging people to join, because physicians alone can't do it. The community have to be part of it. And one of the stipulations of the grant is to work with the community, the state, the Medicaid office, Medicare office, so that everybody is involved in that, because it's for all of us. We're all parents, we're all brothers and sisters, we're all family members who are affected. And one group will not be able to do it alone. It takes all of us to push together to have those changes. Necessary. And when you mentioned the cost of gene therapy, the cost of those things are expensive, and there's good reason why they're expensive, because it does require a lot. But as we do better, prices should come down and affordability should come down. But that should stop us.
I've been involved in research for a long time, and this is the highest time, as Dr. Pollard said, on where they're giving out money and funding for treatments for health equity, healthcare disparities. So I think that it is time that the sickle cell community really, really band together, find an area that you want to join, where it's the SCDAA, whether it's the Office of Minority Health, whether it's our clinical trials network. If you want to talk to any of us and say, hey, what would fit well for me? That would, be great. My experience with when we ask patients to join these things, everyone's is very shy. The sickle cell community as people, they're very shy, and they think that their voice may not count, but it actually counts more than ever, and we welcome it. We'll help you find your voice and be present. So don't not be part of it because you think that you can't speak up. Once you're in the community, once you join these networks, there's help out there to help you speak up. And we don't want other diseases that have gotten attention to continue to get money under this period of time where it's actually, this money is meant for sickle cell disease. You guys deserve it. And that's the way you got to feel, and you got to fight for it, because there are other diseases that are fighting for this money. And you got to just feel really empowered to say, it's about time. Sickle cell disease needs this money, needs this research, needs these treatments so people aren't getting strokes and aneurysms and things like that. We need to get mad and we need to get involved.
If I can say, in terms of research, just what.
I don't need a mic. I got a big mic. I want to say thank y'all very much. Came from Jersey, come out here.
Oh, you deserve a round of applause.
For Jackie Chan, I wore my T-shirt for Jackie Chan. My T-shirt says,
yes,
right now, but I'm sorry to take it. I want to say thank you very much, and I'm a fighter because I'm from this neighborhood. I was born here. My kids were born here. I'm from South Jamaica. People don't want to speak about. I don't know what they think to look like, but I think I'm cute. I don't think sickle cell is written up here. I think I'm, but I want to thank you very much. In your time, if you don't stop, thank y'all very much.
Thank you.
Headed back to Jersey to pick up my grandbaby.
Thank you. Thank you.
Just to follow up, in terms of research, right? When I look at I get all the research, all the medical magazines at the end of the month, JAMA, and you look at all the Cleveland Clinic and Harvard Medical School, and and just go down everybody has a magazine every month that they bill you for and send you information every day. And I'm always wondering why there isn't enough research on sickle cell. Not one time, and I've been receiving all these magazines, and everything is about high hypertension, high cholesterol. I mean, the four horsemen of the killers. I mean, blood sugar, but yet you would see on cancer, but nothing on sickle cell. What is going on in research? But relative to the big universities, the ones that have all these endowment and big money and who could spend all this money in terms of research and really sending their people out and do the work, why is it not reaching down to the sickle cell? What is going on with research?
First of all, several points. Compared to like heart disease, high blood pressure, and everything, sickle cell disease is considered a rare disease, believe it or not, because it affects 100,000 people. Too many people, but if you look at heart disease, they do one trial, 5 million patients participate in that trial. They have an answer in 6 months, and it's published in the most prestigious medical journal. That's how their trials work, just to answer that question. Second thing is funding, right? Is there enough funding to do research in sickle cell disease? And I think in the past, there definitely was not. I think there is definitely a huge interest in sickle cell disease right now. And there is much more funding than there was in the past. Maybe not as much as cystic fibrosis, but there's still so much more funding now for sickle cell disease research. But to be able to do a successful research study, to complete a trial, you also need participation. So you may have a study, and we have seen it way too many times. The drug company comes out with a new drug and wants to try it in sickle cell patients. But if you have 5 patients enrolled on the study, they cannot answer any question about the drug. So they close the study. This was happening so many times that the American Society of Hematology finally decided we have to bring all the people living with sickle cell disease together. So when we have a new medication like this, we can, offer it across the United States to all the people living with sickle cell disease and get a meaningful answer in a shorter period of time. We'll see if hopefully if this was tried a couple of times before and has not been very successful, we'll see if this time it will be successful. We are hoping so. So the other say, I always say to my patients as well is, remember Dr. Appiah-Kubi mentioned we are giving penicillin to all the babies born with sickle cell disease because we don't want them to die of an infection that we can prevent, right? How did we learn about that? Research. What does that mean? Those babies, the parents of those babies, enrolled the babies in a clinical research study in the 1980s, and we came out with that information. Now we are preventing millions of lives all around the world by putting them on penicillin. But we were able to do it because those parents trusted us. They put their little baby in a clinical research study, and we were able to answer that question. The same thing happened with transcranial Doppler test, the stroke screening test, and whether it was one, giving accurate information. Second, if we transfuse those children, can we prevent a stroke? We were able to answer that question. So that's why I think open communication between people living with sickle cell disease and their providers and the medical community is key. We have to trust each other. We have to listen to each other with an open mind. Ask your questions. We are here to answer questions. We are going to be honest with you, and we are going to tell you the side effects. We are going to explain everything. But without clinical research, we cannot go anywhere. Gene therapy, that's clinical trial. That patient decided, he talked for a year before he made the decision. It took a long time. It's not an easy decision to go through gene therapy. But at the end, he decided he wanted to do it, and he did it. Now, thanks to him and thanks to 50 other people in the country, we have the information. We are going to FDA. So if these people did not do that, we cannot go to FDA and say we have a gene therapy trial for sickle cell.
So I wanted to elaborate on that as well. I do agree that sickle cell disease is considered a rare disorder or an orphan disease, but it's actually one of the highest of the rare disorders. So you still have strength in numbers. When you look at cystic fibrosis, that also is a rare disease, but is getting more money and is getting more studies going out and things like that. And we do need that participation and that trust. And, I do want to relate to you that a clinical trial isn't something that's just done to you. It's something that's very well discussed. Like a lot of my patients, I have many discussions with them, and sometimes they decide to do it and sometimes they don't. The worst thing that I see is if someone doesn't even want to talk about it or have the discussion. So just be open-minded. Not every clinical trial is for everyone. But if you have an open mind to clinical trials, many people can join and will join. And it's meant to be kept safe. I know I'm a nurse. I'm only dedicated to the research patients. All my patients have my 24-hour number, 7 days a week. They could call anytime. We want them to use it, and we want them to be safe during the clinical trial. The trial is never more important than the patient. If something's starting to not look like it's working, patients have the right to quit. We have the right to quit them because we might think that, hey, a blood test, this is not good for them. But if it works for them, it's really a home run. And then we could go to the FDA, and then everyone can get it, and we'll have many more medications for people that maybe hydroxyurea doesn't work for, and other medications that we have now, the handful of medications we have now may not work for. And we know there are better medications out there in the future. We know that. We just got to make sure the funding is there and the people are there to, support it. Both the doctors as well as the patients are supporting those efforts.
This is an excellent point in terms of the protection of patients and doing research. This is the biggest hurdle for all those trials because, believe me, things have changed tremendously from the past. And now the protection is really, really tough to get anything passed that the patient is not protected. Like Linda says, patients come first. And the government, all the watchdog, the institutions, everybody is involved into making sure that everything is tested and done properly so that the patient is protected to the maximum during any of those trials.
Hi, my name is Marie. I'm a patient of Ortho for the past 6 years. My first question is, any studies being done to see if there are less children being born with sickle cell now compared to the 60s when I was born? I'm 54. My parents didn't know any better, so I end up with sickle cell. But nowadays, with so much education going on, are there less children being born with sickle cell compared to in the past?
Is no. When we look and compare cystic fibrosis and sickle cell disease, if you've had one child with cystic fibrosis in your family, you will go through whatever counseling, whatever procedures you need, so you will never have another one. The work is so intensive in the family. Sickle cell disease is more episodic, and families, if they have one child with sickle cell disease, they will have other children with sickle cell disease. So when we compare cystic fibrosis and sickle cell disease with regards to primary prevention, which is the prevention of someone with the disease, there has been no change in that in the United States.
Is it because of not enough information to the family members or to the young people, young Black people,
So the question about primary prevention of a disease is quite ethically complicated. It's your decisions to decide what genes you're going to pass on to your children. Historically, and it's still on the books in New York State, before you got married in the 1970s, there was a law passed in New York State that said if you were non-Caucasian and you were non-Asian, you needed to get sickle cell trait tested, get hemoglobin electrophoresis tested for sickle cell trait before you could get a marriage license. Okay, that is horrendous. Okay, governments shouldn't be deciding what genes you pass on. So there was a tremendous backlash about primary prevention. The leader of sickle cell disease was, there was the hemoglobin molecule in sickle cell disease was Linus Pauling. Linus Pauling recommended that people get an A or an S tattooed on their head to do primary prevention. Okay, Linus Pauling was not a racist. He did this well-intentioned, okay? He was not. It's the only thing he ever backed down from in his life. Okay, he realized what he said afterwards. He presented this at meetings. Okay, so it's a hard decision to make. People with sickle cell disease have a variable quality of life, but there are good periods of times, there are bad periods of time. So it's a hard decision. Did that answer your question? Yes, please.
I'll just add, you know, here in the United States, we have newborn screening, right? So you would hope that the parents would know the status of the child. Now, by the time the child is ready to start their own family, are they able to pass that information from the parent then to the child? There might be a lot of drop off there. And so you almost need a second round when the child is now ready to start their family for a second education, right? And despite how much sickle cell we have here in the United States, 100,000, the bulk of it is actually not here. And in those countries, they don't easily have newborn screening. They're trying, and a lot are getting there, but it's not as it is here. So then there are all those children who were still being born, but they do have certain things in place in a lot of African countries to try to prevent it, but still it's not. So newborn screening is great because then we can start them on penicillin and everything like we discussed. But then for that primary prevention, I don't know if newborn screening definitely gets the primary prevention done, because that child with the trait, they may not know they have the trait because either is the parent even alive to tell them. You know, things happen. So
I may add, you know, we all went through it. Doesn't matter what the and thoughts, but it matter what is.
Yeah, I can relate to that. Arturo has been telling me, Marie, any procedures before you travel, you need to come to get infused. A month ago, I fell and I broke my shoulder. I fractured it. They said I didn't need surgery. 3 weeks later, I had the MRI. I need surgery. I went to see the trauma surgeon on Monday. Surgery is scheduled for Friday. Wednesday, they're telling me, no, you need clearance for hematology. I'm like, listen, I need my shoulder fixed. It's already 3 weeks. What are you talking about? They says, no, unless where you go for sickle cell treatment clears you, we're not doing the surgery. Wednesday morning, I was screaming on the phone. I'm like, listen, you need to clear me tomorrow because surgery is on Friday. You need to sign the papers. He goes like, what papers? I'm not signing any papers. You need to come. I said, listen, it's Friday. Today's Wednesday. Thursday is the only day I have to get everything ready for Friday. He says, no, Marie, you're coming tomorrow, Friday. I came Thursday. Came Thursday. I got infused. Then I had the surgery on Friday. Everything went well. And I have to say thank you, Arturo. But like you said, sometimes information is given, you're not thinking about it. Until it happened to me now. I was like, oh, all these years he's been telling me. And now it happened. And yeah, and I was grateful that you took me on that Thursday, Arturo. Okay.
Thank you.
Thank you.
All right.
I just want to add something. I think that, you know, it's so interesting what you said about the history, about looking at the trait. But, you know, it's very interesting that I've done research with a lot of different diseases, cancer included. Cancer is not historically a genetically inherited disease. 5% of those cancers are inherited. But once people started to become aware that inheritance could be a part of cancer, it's tested a lot, a real lot. And we know 100% of sickle cell patients, you know, are tested. And 1 out of every 12 African Americans could have the sickle cell trait. But when you ask people, they actually don't know their status. And so this becomes a point, again, part of this symposium, and the purpose of this symposium is not to look at, you know, the potential for inheritance as being, oh, a bad thing, and we need to put something as their scarlet letter. but to, you know, open up the discussion that this is part of who you are, this is part of your family history, this is something to watch out for, and not something to just get while you're married or while you're having a baby. It's something to know about who you are as part of your persona. And that's what other genetically inherited diseases are. And again, I've started my career with genetically inherited diseases, and it's not looked at like the way everyone just looked at that story. It's looked at as part of this is who you are. And that's the place I'd like to see sickle cell be in, is to be in like the way cancer is, the way other diseases are, and to just have that conversation and have it with pride and say, okay, you're at risk for this, and this is what you need to do because you're at risk for this. They even talk about, you know, people with the trait, when they exercise, they might get muscle breakdown, things like that. They might have that for years and years and years, and then all of a sudden they find out they have the trait, and they suffered. We actually don't know what the medical history is on people with the trait because it's not studied. So this is another area. We got to be open-minded and have open discussion and realize we all need to be involved.
Yeah, I just want to know, so I have the sickle cell disease and I want to have a baby. How do I get a baby without sickness? Because I don't know how that works.
Not to give very specific advice, Romain, but one is I think it's really important for your partner to be tested to find out if that person has sickle cell trait or not, right? So that will help you decide. And then currently there are technologies, right? So, you know, we talk about there are technologies right now like in vitro fertilization, where actually you can select an embryo that doesn't have sickle cell disease. It is, yes, it is technically, it's medically available. We have used it. It is expensive. There are ethical considerations around it. So I'm not saying it's an easy thing to do, but it is available.
Just that I want to know. I want to have my kids, but I don't want him to go through what I've been going through.
I just want to make a comment in regards to children because for me, after growing up and seeing how much I struggled and the amount of hospitalization, I made it a personal choice when I was dating to find out before I even get involved with someone, before I even get to the stage where I want to know if I like you or not, you know, much more to have a child with you. I chose to ask that person if they know what sickle cell disease is. And if they said they didn't, then I would provide them information about it. And then I would ask them, do you have it? Have you ever been tested? You know, if they know what it is. So it was a personal choice. That was my choice. So that's one of the ways to prevent you having a baby with sickle cell disease. So when I met my daughter's dad, that was one of the things I did. And even when he said he already knew about sickle cell disease, I still gave him information about it. And even when he said he didn't have the trait, my GYN, she was very good. She was like I wish she could be everyone's GYN, honestly. That's how good she was. She didn't just take his word for it. He had to be tested and brought her that result that he was not a carrier of the sickle cell trait because I knew I wanted to have a kid. So and even if I like you, before I know if I love you enough to have a baby with you, I need to know your status. So that was my personal choice. And thank God, my daughter only has a trait, and that's because of me, because I have sickle cell. So she has a trait, but she doesn't have the disease. So it's my job to educate her as she gets older to make sure if you want to have children, you have to make that choice to make sure your partner doesn't have the trait, because it's a 50-50 chance that her kid will have it. Because my parents was not educated. Even to this day, my mom has never been tested to say she has sickle cell or thalassemia. She doesn't know which of the genes she carries. I know my dad has a sickle cell trait because my other siblings have it.
Any more questions?
For this exciting discussion.
Tonight, today, really, it was yeah. Usually my radio show's on Saturday night, so that's why I say thanks tonight. So, I'll keep talking about it on my show, Sickle Cell, and spreading the word around to the community. I try and engage the community to please step up and get involved. And we will keep on top of this, and we'll give it all that we have. We got to fight this, and we all need to come together. So again, please listen to my radio show every Saturday, 91.5 FM WNYE. It is the greatest Calypso show in the world, and you will not be disappointed. We would mesmerize you with Calypso music, and of course, we'll challenge your brain. We'll take your brain back into the 60s or 70s, which is good for your brain. You get to exercise your brain when we take you back in the 60s. You think about Calypsos your parents grew up with. So, it's just not brain stimulation. It's also music. You get to dance, and that'll help you to get your heart rate up. So that's a good thing, right, docs? That's a good thing, getting your heart rate up. Yeah. So, so thank you for coming out. Thank you for the symposium. Thank you to, of course, our friends. And we have to introduce our friend here to come and say a couple of words here first. You're on the list. Yes, Yadira. Thank you for coming.
Hi, I have slides. I don't know if will it work?
Who's that dog?
Yeah, it should be already loaded. Good afternoon, everyone. I know I'm probably between everyone leaving, so I will be very brief, but I do have some good information to share. Thank you so much for the panel.
Which one it is? Okay. Okay. Yadira. Which one?
I'm sorry. No. Here we go. Does this microphone work? Should I use this?
Okay.
Great. So again, my name is Yadira Navarro. I'm Director of Community and Stakeholder Relations for New York Blood Center. I'm so happy to be here this afternoon. I'm so happy to partner with Merlene and Molino and her entire team at the Sickle Cell Awareness Foundation, Corporation International. If you know them, you know how hard they hit the streets to bring out information and to make sure people are aware and are making change. And we're so grateful to be here at Queens Hospital, New York City Health and Hospital Queens, that does such great work for the community. In regards to our work, Queens Hospital has been a fantastic advocate. So we'll get into that in a second. Just so you know who we are, we're the third largest blood independent nonprofit community blood-based center in the world. We have a 4-part mission. We're providing the highest quality blood and stem cell products. We're conducting innovative research, which is a standalone that we have to offer. We have additional products and technologies with a humanitarian impact, and we're really proud to train the next generation of leaders in our industry. So we're across the nation, but our home base is here in New York. And we're about to hit our 60th anniversary. We've served almost 75 million people through partnerships with more than 600 hospitals. So we're really proud of the work that we do. At New York Blood Center, we're really proud to have the largest rare blood inventory in the world. And to the panelists, I know there was a mention of how important it is ethnicity when it comes to blood, when it comes to sickle cell patients and blood types. So we are so proud to have the largest rare blood bank. We actually take those units and we freeze them so that we have them on hand. We have had sickle cell patients that have spoken and been advocates on behalf of the blood supply. And we had one in particular, if anyone remembers, Davina Daniels. She only had 4 people throughout the country that had her antigen makeup to get the transfusion she needed when she went into crisis. Unfortunately, she has since passed, but it just shows the importance of having a diverse blood supply on hand. And again, we're very proud to be a leader in sickle cell disease research and support. So again, not only providing the needs for transfusions, but also developing treatments, stem cell therapies, and partnering with community allies to get awareness out there. The pandemic, as everyone knows, devastated so many parts of our country, and the blood supply was no different. The blood supply nationwide, and I would say across the world, was severely impacted by the pandemic. People were home, people were not in their usual places of business, schools, and we were not able to host the drives that we normally could and would. And as a additional effect, it affected the diversity of the blood supply. So you'll see on average pre-pandemic, about a little more than a quarter of the blood supply was represented by diverse communities. And at our lowest point, it really got to a very small amount. Only 20% was non-white donors, which is a problem. Again, for those who need very specific blood, we did not have it on hand. So we are getting better, but it's important that people know that this is an important thing to do, donate blood. It's also important to know that antigens, which again have your ethnic makeup, and they provide added help for patients who need critically and closely matched blood. The Black and African American community has the highest percentage of those with rare antigen blood. So it's really important. I would say that the blood is more valuable. It's extra special, right? It provides that extra impact. Now, as far as our efforts, we work very closely with different organizations to, again, have opportunities to share the need and what people can do to make a difference. We love to recognize the efforts done. So I know last year we had a wonderful proclamation by City Council Speaker Adrian Adams to Merlene and the organization. Sickle cell trait testing came up. So, you know, their slogan is health is power, right? And absolutely, we want to help people understand. It's important to know your blood type. It's also important to know, do you have sickle cell trait? And although there is newborn screening, a lot of times, as you mentioned, people aren't sharing that information. Even blood types, you know, we get screened early and people often don't know their blood type. So it's important to donate and have access to that. And we have been increasing our free sickle cell trait testing to donors in select areas to allow for that. A big thing that came up earlier in the conversation also was many people associate sickle cell disease with the Black and African American community, and that's not necessarily the case. So it's important for us in our efforts that we're doing now that we bring a diverse set of sickle cell patients to the forefront, to share their stories, to let people know that this affects a broader community than what traditionally has been shared. We also have been testing our donations in select areas for the rare antigens so that we can identify these special donors and have the blood ready for the patients that need it. And in my line of work now, we're finding different community stakeholders. Who are the people that are very influential, that can share the progress in research, that can share the need for diversity, that can share, you know, what's important to the community and be that extra voice. I think it's so important, as someone said earlier, this is the time, you know, of all the terrible things that came from the pandemic, one of the positive things is people realize the discrepancies and the health disparities that exist, and that certain communities don't get the attention and the funding that they need. And now is the time where people are starting to realize we need to make a change. So putting your voice out there, it definitely helps. We also, for Sickle Cell Awareness Month last year, we had a wonderful special introduction of one of our patients or one of our recipients, Shatira Weaver, who is a sickle cell, she has sickle cell disease. She thrives. She works for the Department of Education. She's an incredible person, inside and out. As you can see from the photo, and as was mentioned earlier, you would never know she has sickle cell disease. You know, she carries herself in a very strong and healthy manner, but she has required that. I wonder, I don't know if it'll show the video, but we did introduce her to one of her donors. And again, it was a wonderful opportunity to just showcase that we need each other. And with all the novel treatments and all the medications that are coming out and being developed, it's blood that are carrying these patients as the progress is being made. So it's important for people to know that this is a very simple act that makes such a huge difference. It takes about an hour, right? Really takes about 45 minutes from start to finish, from filling out the form to getting the cookies and juice at the end, because everybody does get that. And that's usually the biggest motivator for donating blood. But you literally save lives. There's nothing else a person can do. There's nothing else we can do with that donation, but save a person with that unit of blood. So it's important to do that. How you can help? Donate blood. If you're eligible, this hospital does an outstanding job of sponsoring blood drives. And they started their campaign during the pandemic. So when it was the hardest for people to do blood drives, this hospital stepped up and has done an incredible job. So find locations where you can donate blood. You can absolutely go to our website, www.nybc.org, find a blood drive near you, and take the time to donate. If you personally can't donate, let your friends and family know that this is an important thing to do, and it's simple. There's a lot of misinformation out there. People are concerned, is it safe to donate? I don't have enough blood. It's not true. Give it a chance. More often than not, every time a person comes to donate blood and they had their fears and reservations, they did it, and they find that it's a very simple and very rewarding experience. Spreading awareness, so even on your social media pages, word of mouth and having those conversations with people, newsletters, however you get information out there, put the information out there so people know it's a great thing to do. And volunteer. Come to one of our blood drives. Spend some time talking to donors. Volunteer your time with Merlene and Molino, just to let people know that this is valued. The change comes through numbers, through our voices being heard. So just make sure that you're out there and you're making a difference. And that's all. So again, I wanted to be quick because I know everybody is anxious to get out. But thank you. We appreciate your time and your support.